Saiti, you can, it is live stream. We are live now. Saiti, please share the screen. I will start the program.
Sure, sir.
So, good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcome you all in the knowledge sharing webinar. Live now. Saiti, please share the screen. I will start the program.
Sure, sir.
Saiti, some volume is coming. So, it's my honor to introduce today's MOC, Dr. Kanchan Sharma, madam, in the knowledge sharing webinar. Live now. Saiti, please share the screen. I will start the program.
Sure, sir.
Saiti, some volume is coming.
Sir, I'm checking.
So it's my honor to introduce today's MOC, Dr. Kanchan Sharma, madam, in the knowledge sharing webinar. Saiti, some volume is coming. Start the program. Saiti, some other platforms volume is coming. Saiti, some volume is coming. Madam, am I audible?
Sir, I'm checking. You
So
are
it's my
audible,
honor
sir.
to introduce today's MOC, Dr. Kanchan Sharma, madam, in the knowledge sharing webinar. Saiti, some volume is coming. Start the program. Saiti, some other platforms volume is coming. Some volume is coming.
Sure.
Madam, am I
Sir,
audible?
I'm checking. You
So
are
it's my
audible,
honor
sir.
to introduce today's
I think your device is echoing.
madam in the
Your
knowledge
two
sharing
devices may be
volume
open.
is coming. Start the program. Saiti, some other platforms volume is coming. Some volume is coming.
Sure.
Madam, am I
Sir,
audible?
I'm checking. You
So
are
it's my
audible,
honor
sir.
to introduce today's
So, what happened?
madam. Just wait, there are some technical issues. Just 1 minute. Sorry for the inconvenience caused. Actually, there is some technical issue, so just we are starting right now. So thank you very much all the participants and doctors for joining this knowledge sharing program organized by Kanpur Obstetrics and Gynecology Society. Sorry for the inconvenience caused. Actually, there is some technical issue, so just we are starting right now. So thank you very much all the participants and doctors for joining this knowledge sharing program organized by Kanpur Obstetrics and Gynecology Society. Sorry for the inconvenience caused. Actually, there is some technical issue, so just we are starting right now. So thank you very much all the participants and doctors for joining this knowledge sharing program organized by Kanpur Obstetrics and Gynecology Society. Sorry for the inconvenience caused. Actually, there is
Let me start. I think my voice is not echoing.
Madam,
I
now
think
it
my
will.
voice is not
Madam, the problem has been resolved. Sahiti, please share the screen.
Okay, sir.
So sorry again. So it's my honor to introduce Madam and Dr. Kanchan Sharma, Madam. Madam is the Director and Chief Consultant, Akash IVF Center, Kanpur, and Madam is the Secretary, Kanpur Obstetrics and Gynecology Society. And Madam is the active member and dedicated to FOXY, Activity Working Female Breast Committee, Awareness Committee, and Adolescent Health Committee. FOXY, and Madam has conducted many national and state level conferences, delivered more than 2,000 talks in different platforms, and got many awards to her credit. And this year, Madam is contesting as a chairperson of Female Breast Committee FOXY. So I'd like to request all the delegates and doctors for their blessings to Madam by voting and supporting. So in this short introduction, I request Madam to take over the session for further proceedings. Thank you very much. And over to you, Madam.
Thank you so much. All the respected dignitaries and great leaders from Tamil Nadu, my sincere regards to all of you. I'm Dr. Kanchan Sharma and got the privilege to welcome and take the blessings from all of you. Today's our chief guest is my own most respected and beloved ma'am, Dr. Ramani Devi. Guest of honor is none other than the president of TNF. She is Dr. J Lakshmi ma'am, and there are so many. Dr. J Kanan, so senior person of the Tamil Nadu. I'm blessed by taking her blessings. First of all, I just want to start the session by taking blessings from that Almighty God. His divine power has granted to us all the things that pertain to life and godliness. So make every effort to supplement your faith with virtue and virtue with knowledge and knowledge with the self-control and steadfastness that gives rise to godliness. So, shall we start our session by lamp lighting? Please, all the dignitaries, Dr. Charmila, Dr. Asha Rao, Dr. Ramani Devi ma'am, and Dr. J.M. Khanna ma'am, very senior person, please join us, all the chairpersons, all the guest of honors, for the lamp lighting.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya deepajyotir namostute deepajyotir namostute shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनं कुरु.
Thank you very much. Just to start the session, I am inviting our chief guest, Dr. Ramani Devi ma'am, just to take the blessings. Kindly show her CV. She's our chief guest. She is past president. Ma'am, this is a virtual beautiful bouquet for you. Thank you for blessing me. To succeed, I was just talking to ma'am just before the session, and I learned from her, to succeed in your mission, you must have full-heartedly devotion to your goal. Ma'am, that you teach to me. Thank you. You are a managing director of Ramakrishna Medical Center, LLP, and Janani Fertility Center. You won 10 gold medalists during UG and PG periods. You are the winner of Professor C.S. Dawn Prize 2006, 2007, and 2013 as the primary author of Indumati Jhaveri Prize, and you were the chairperson of Endometriosis Committee FOXY in 2014 to 2016. You got the Woman of the Year award by university in 2013. You got the Women Achiever Award you got by the Citizen of Trichy in 2015. You got the Dr. APJ Abul Kalam Award 2016. You got the recipient of Dr. Navamani Bose and Dr. Rameshwari Nallaswamy Oration. Recipient of Dr. Datta's Award for the Best Foxy Focus 2016. You got the recipient of Dr. Mehru Dhara Hansotia Award for the Best Committee.
I think
Ma'am, you are really my my inspiration and my guide. You are ma'am, got so many awards. You did such a have so many feathers in your cap. We have to follow you, ma'am. Please and please bless me. Thank you.
Thank you, Kanchan, for the nice words. First of all, good evening to everyone. Respected J and Madam, senior most person from Trichy Society, and all the other guests of honor, Dr. J Lakshmi Madam, Dr. Vidya Duppi, Dr. Revati Janigram, and Dr. Asha Rao, and all the faculties, Dr. Charmila, Dr. Usha, Dr. Malini, Dr. J Lakshmi, Dr. Purnima, Dr. Kanchan, Rekha, Saravana Kumar, then Chitra, Mary, Genova, then Deepa, Dr. Jyoti Sundaram, and Dr. Shanta, Dr. Umayal, Dr. Shanti Rani, Amala Devi, Saroja Velusamy, Radha Madhavi, Chandra Vanita, Dr. Geetha, faculty speakers as well as chairpersons. I think this knowledge sharing gives a very important, they have taken up important topics like adolescent PCOS, which is increasing in incidence, and uterus that holds the fetus, time to release by none other than our Dr. J and Madam, and thin endometrium, which is always a problem in ART, preparing for ART FETs, that will be dealt by Dr. Kanchan, and thrombocytopenia in pregnancy, though it is not very common, but we have to learn about it. That is the two from the mouth of the great speaker, Dr. TV Chitra, and the panel discussion on very important cases on obstetric emergencies. That's being conducted by Dr. Shanta and Dr. Umayal Murugesan. With this, I think I wish Dr. Sharma, who has already done an Kanchan. I think we have Dr. TV Chitra, who's also going to contest for the post of chairpersons. I wish them all the best. And I wish this program a great success. Thanks for the opportunity given, Dr. Kanchan, and wish you all the best. Thank you.
Thanks, ma'am. This is my privilege and that you have given me these blessings, ma'am. Thank you for your blessings. We were waiting for Dr. J Lakshmi, ma'am, as a special guest. I think she has not yet joined. And Dr. Sampat Kumari, ma'am, was also busy in medical college taking the examination. Dr. J Kanam, although she is a speaker, but she is a senior most person. So, ma'am, from your mouth, just we want to hear. Your CV will be shown while you will be the speaker. Please give us 2 words for the blessings. Thanks, ma'am.
Dear Kanchan, please do not put my CV too many times, because all people down south know Jayam Kannan as a senior most gynecologist, and she can give lectures properly with evidence to date. That is the only thing. And Charmila is smiling, and Charmila knows well that the day before I go for a web, I always put the last date and ask for the subject details. That is how I get updated. Okay. And regarding your chairpersonship contest, yes, it is really a one which Nowadays, we are facing a lot. Right from the year 2012-13, there have been always 3-4 contestants for many posts, like Charmila had 4 contestants, of which 2 were from the top of West and North. And
Varema?
Charmila had like that. If you are able to work, call everybody properly and talk to them, because many of them may not take the phone. Please understand. See, even in for my panel webinar as a chairperson, I call people, they don't take the phone. So don't worry about not taking the phone. Even if you make an attempt, that is more than enough. Please send a phone call followed by an email message saying that I tried to call you. They may call you, or they will definitely remember your name. This is for your chairpersonship. For this webinar, I'm very happy that you have clubbed up all the Satan people where I'm able to see everybody. And I know well that all the speakers who have been put up here and the panelists are excellent people in so many webinars in the COVID time. Shantirani would have been really tired of doing webinars as a HOD of Deni Society. I know and Deni Medical College. She should, because with Corona work, with obstetric gynec work, with all this webinar work, I know how much she was drilled just for one message, which I would like to give. So you will definitely screw up to your post and keep it up. And thereafter, come up unopposed, like what as Charmila had done because of her untiring work in the last 2 years. Right from 2020 August, she started doing this work. And in 2022 February, she has got the news. Okay, you will also get it like that. May God bless you. May me also bless you.
Thank you, ma'am, for your beautiful words of blessings. These words matters a lot to me, ma'am. Thank you so much. There are no words to thank you for your blessings. Thank you so much, ma'am. You are such a senior person.
Thank you.
Shield Connects, please show the guest of honors CV.
Yes, ma'am.
I think Shield connection is little unshielded. It is unshielded.
Please do fast, because we don't have to waste the time in this all. No? Do fast. Yeah. So, chairperson, guest of honor.
Asharam ma'am CV.
Dr. Asharam CV. Asharam.
That is where Charmila stands, you know. She can quickly pull up these people who are conducting the webinars.
Fast.
So many coordination.
Charmila is young programs which she has done.
Charmila has so much energy oozing out of her.
Thank you, ma'am.
So, our guest of honor is Dr. Asha Rao. She is MD DGO FICOG. Madam, welcome you. We are pleased to have you as a guest of honor. This was your virtual bouquet. You are the chairperson of Endometriosis Committee, FOXY 2020-22. You have an experience of 25 years in ART and director of
I think that's enough.
Rao Hospital, and got so many awards, and you are organizing chairperson of Yuva Foxy, IAG Star, Endogynec Conclave, and so many gold medal from President of India, from the university in the final MBBS, and delivered the first ICSI baby of Coimbatore in 1998. Ma'am, you are such a great person.
Thank you, Kanchan.
Yeah. Thank you, ma'am. Just bless us.
Yeah. Thank you so much, Kanchan, for those kind words and for having invited me here today to share this guides with so many eminent and senior faculties like Dr. J Kannan, Dr. Ramani Devi, J Lakshmi, and Vidya Tobi. And you, Kanchan, are always smiling, energetic, enthusiastic, and dedicated to your work. We wish you all the best in your future endeavors. And today we have a vibrant scientific program, and lovely speakers like Dr. J Kannan, Dr. Charmila, and our own Dr. Chitra from Coimbatore. Once again, I wish Dr. Chitra the best for her election too. And we are going to have a very interesting panel by Dr. Shanta and Dr. Umayal. And it's lovely seeing so many faculties from South gathered here. So let me not stand between the delegates and the grand scientific program. Once again, Kanchan, I wish you all the best in the forthcoming election, and the same to Dr. Chitra, and wish you all the best for the webinar. Thank you.
Thank you, ma'am, for your nice words, wonderful words. Thanks for blessing me. The next CV you can show. So is that keep on that share screen so that we can just come on the next CV. It will not take much time. Thank you, Dr. Asha Rao, ma'am, for your nice words. I'm obliged.
My pleasure, Kanchan.
Hello.
Secret of success.
Good evening, everyone. This is Dr. Revati Janakiram.
Dr. Kanchan, another guest of honor joined, Dr. Revati Janakiram.
Okay, madam, welcome, Dr. Revati Janakiram.
Thank you.
Madam, welcome here as a guest of honor. This is a virtual bouquet for you. You are the past vice president of FOXY. You are professor and MD, DGA, MN, AMS, FICMCH, FICOG. You are a former director of IOG Chennai. You have a teaching experience of UGs and PGs for last 40 years, ma'am. You delivered many lectures in national and international OG conferences, CMA and IMA meetings. You are the invited guest speaker on Nepal OG annual conference at Kathmandu. Delivered Professor Krishna Menon oration at OG SSI in 2017 and Professor KBR oration at Madurai OG annual conference. You organized many CME and national conferences, research methodology workshop at Madurai and Chennai. You are the past president of MOX Madurai, president IMS Madurai chapter, president MCOT, recipient of FOXY Dr. Durusha Community Services Award. Even you got the Lifetime Achievement Award of IMA Madurai, madam. Selected as the master trainer of PPIUCT program by FIGO FOXY, and you were the author of FOXY Focus on Amniotic Fluid A to Z. So many, you got the Pride of FOXY Award in November 2019 at Mumbai. Madam, welcome for your blessings. You got such energy and such a brilliant CV, madam. Please bless us.
Thank you. Thank you, Dr. Kanchan Sharma, for your kind invite. It's indeed a great pleasure to be part of this mega webinar. And really, sharing knowledge is a great service. And I congratulate all the speakers of this webinar. And you know one thing, because of webinars of late, a lot of webinars going on each and every day, the same topic may also be repeated. But the advantage is that it is by different speakers. So same topic from each speaker, we learn something new. So that is the advantage for the audience also. So in that way, we learn a lot, audience learn a lot from webinars, and specifically you have chosen a nice topics like adolescent PCOS, thin endometrium, and all those things which are practically very, very important. And I really congratulate you, and I wish you all the best for your breast committee chairperson. Thank you very much.
Thank you, madam.
Can I say one word about Revati? She is a great Veena artist also.
Thank you, Dr. Jayam, for a long
Other
time.
side of Revati. I know her as a MBBS student at Madurai itself. I know her enthused.
Thank you, Dr. Jayam. She is my senior and she is a role model for so many people.
Good, madam, because my both the sons, they are playing, they are not playing Veena, but they are, because they are son, they are playing guitar, and they did Prabhakar in the guitar and bandolian.
Nice, nice. Thank you.
to
Thank you.
have
Thank you very
that
much.
thing
Thank you.
from you, because you said that practice is an essential factor for mind management in all the fields of the human endeavors. So hearing the same topics again and again make human mind perfect. I agree. Our other chairperson, Dr. Vidya Dobi, ma'am, I think is not able to join. She has not joined yet. So we are waiting her to join next, coming on the academic session. For academic session, my co-moderator is Dr. Shanti Rani. I just please present her CV. Keep on sharing the screen. Yeah. So Dr. Shanti Rani is the president of Theni OBGY Society. Ma'am, you did a lot much of work with me just to prepare and sketch this webinar. This is a virtual bouquet for you. You are the professor and HOD in GTMCH Thani, president of OG Society Thani. You are the South Zone Coordinator, Medical Disorder Pregnancy Committee Foxy. Best Doctor IMA Award you got. You got Best Service Provider Award for PPISUD and Lab Sterilization, Special Interest in High Risk Obstetrics. So I give mic to you for conduction of the scientific session, ma'am.
Kanchan, Dr. Shanti has lost her connection, so she's asking you to continue. She will just join in 5 minutes.
Okay, ma'am. So let us start the first session. I just invite the chairperson of the first session. Dr. Usha Goenka, my president's message was there because she is busy, stuck up in some surgery, so she will be joining a bit late. So come on the second chairperson, Dr. M. Malini. She is the secretary of Karur OGY Society, and this is a virtual bouquet for you. Her CV, she is assistant professor at OG GMCH Karur, consultant at Shri Vinyaga Clinic, secretary Karur OGS, special interest in high risk obstetrics infertility. So you may introduce our great speaker of the day, Dr. Charmila ma'am. Dr. Malini ma'am.
Thank you for providing me this opportunity, ma'am.
So Dr. Charmila ma'am.
Thank you, ma'am. I welcome Charmila ma'am for the session. Madam is a vice president elect in Foxy. Madam is a past chairperson in clinical research committee of Foxy and ICOG governing council member. Madam is a national coordinator in UNICEF Foxy and Meta Foxy PG program. Madam is a member of many societies and past secretary of Trichy OG Society. And Madam is a president of Menstrual Hygiene Management Consortium. Madam is a joint secretary of Gestosis Indian Society and joint treasurer of IFS and Tamil Nadu chapter. I hand over the session to Charmila ma'am. Welcome you, ma'am.
I have few words to say about the Dr. Charmila. She is one of the great personality I have met because
Yes,
she is
ma'am.
very clear of her concept and always guiding in a very clear way. I have heard her panel also many times for IUGR. She was very clear of her concept. Because of this her clear concept and brilliance, she become popular in all of us all over India. Great congratulations to you, ma'am, for your this vice presidentship. Welcome here. The stage is yours.
Yes.
Thank you, Kanchan. Thank you so much. I'm extremely thankful to you for giving me this opportunity to be in a forum where Dr. J Lakshmi madam is also there. It's a great opportunity for me, and I would like to wish you all the best. When hard work is there, there will be a result, and you should only think about the process. The result will speak for itself. Whatever happens, the process should be happy enough for you, and you should go ahead with whatever you're doing. That should be the I think the point to be done always, don't think about the result now. You should work hard for it and it will happen. I'd like to wish Dr. Chitra Madam also. I'm just seeing her joining for this, and I hope both of you become chairpersons. Thank you so much. Thank you so much for the opportunity. Let me start the academic session. So I think we're running really short.
Congratulations, Sharmila, for
Thank you, madam. Thank you, madam. She was my VP in my first year of chairperson.
Thank you so much.
Thank you so much, ma'am. The talk is going to be on adolescent PCOS. I know, as Kanchan said, you have heard about it often enough, but I think there are some points which we need some clarity on when it comes to the adolescent age group. We know that it's one of the most common endocrinopathy in reproductive age women, and it affects almost 3.6 to 15%. But there are no data to tell how much it's happening in the adolescent age group still, in spite of so many studies being conducted. So the diagnostic features which you need to think when you're thinking about PCOS has been there for a long time. In 1990, the National Institute of Health said you need a hyperandrogenic feature, oligo or annullatory feature, and there should be no other endocrinopathy before you can say it's PCOS. That was a long time back in 1990. Then the popular Rotterdam consensus came in 2003, where they said you need at least 2 to say that it's a polycystic ovarian disease, and that is you need a clinical or a biochemical feature of hyperandrogenism. You should have either oligo or anovulation, and an ultrasound you can have a polycystic ovarian morphology. But the Androgen Excess Society of 2009 was categorical in saying that you need hyperandrogenism to say that it is polycystic ovarian disease. It can be either with oligoanovulation or a polycystic ovarian morphology, but hyperandrogenism is mandatory. So the Rotterdam's criteria is a popular one which you're following for a long time now. So it's oligo or anovulation, hyperandrogenism, which can be clinical or biochemical. Clinical means if the girl has got hirsutism, or which is the other pattern is quite not so common, that's a male pattern alopecia, or suppose it's a biochemical evidence of hyperandrogenism, or it can be a polycystic ovaries on ultrasound. So you need either at least 2 out of these 3 criteria to say that the person is having polycystic ovarian disease. But you also have to remember that you need to exclude the other causes of anovulation, which can be congenital adrenal hyperplasia, androgen secreting tumor, Cushing syndrome, thyroid dysfunction, and hypoprolactinemia. So all this you need to rule out before you can put the patient as polycystic ovarian disease. But please remember, in an adolescent, you need extreme caution before you can label her as PCOS, because menstrual irregularity is common to an adolescent. Hyperandrogenism also happens quite commonly in an adolescent. And you do an ultrasound for an adolescent, you will see some features of polycystic ovaries. So all these 3, which are considered to be diagnostic criteria, are quite common to both adolescents and the disease polycystic ovary. So when do you suspect polycystic ovarian syndrome in an adolescent? So you cannot underdiagnose or overdiagnose. So you need to have some pointers which should help you to tell like whether this patient is going to have polycystic ovarian syndrome, and that is if the child has got irregular menstruation, which can be abnormally delayed menstrual cycles, or if the girl is having a higher BMI and a higher waist hip ratio. Suppose a girl has had pubertal deviations, that is either early menarche or amenorrhea, or she's got hyperandrogenism in the form of early acne, that is at a very young age, the girl is developing acne or hirsutism, or the acne which is developed is very persistent and severe. Suppose a girl has frequent relapses in acne, suppose she's got acne in the facial V area, or suppose there's acne and hirsutism for more than 2 years, you always suspect that there's a hyperandrogenism in this adolescent, and she may be a candidate for diagnosing as PCOS. So you need to know these patterns before you label a girl as having an irregular cycle, because irregular cycles are quite common even in a physiological condition in adolescents. So you can't say it's pathological. So suppose the girl has got irregular cycles less than 1 year post menarche, that is she's attained menarche and it's just 1 year into that, and she's got irregular cycles, do not label her as PCOS now. That may be just a normal pubertal transition. But if the girl has crossed 1 year post menarche and just got one cycle which is more than 90 days, you need to think whether she's going to go for PCOS. And between the years of 1 to 3 years post menarche, she's got a cycle which is less than 21 or it's more than 45 days, she may be a PCOS patient. And suppose 3 years post menarche, the cycles are less than 21 or more than 35 days now, or she's got just 8 cycles per year. That is, she has lost 4 cycles. That means she's having a cycle duration which is more than 35 to 40 days. That means she may be a PCOS patient. or the child has not attained menarche at all up to the age of 15, or she's attained thelarche and it's almost 3 years gone since the breast development, just not attained menarche, that may also be an indicator that this girl may be going for PCOS. So what are the diagnostic tests you'll do in an adolescent for excluding PCOS? Exclude pregnancy, even though she's of young age. Thyroid dysfunction needs to be ruled out. Hyperprolactinemia needs to be ruled out, and non-classical congenital adrenal hyperplasia should always be thought of when the severe hyperandrogenism. And suppose the girl has got a feature of Turner syndrome, we may think of a primary ovarian insufficiency and hypothalamic amenorrhea, which can also happen similar to an anovulated picture of PCOS. Suppose there's a rapid symptom onset or the significant virilization, which can be in the form of a deepening voice or clitoromegaly, and androgen secreting tumor should be ruled out even when there are anovulatory cycles. Cushing syndrome or acromegaly should be excluded when there are physical findings which suggest that condition. There's no need to do lab testing for all these conditions if they are suggestive of, there are some physical findings which are suggestive, and you can do tests as per the as per needed. Do not do all the tests because it can turn out to be a very costly affair for the girl. So how do you manage PCOS in an adolescent? You need to tell the girl that she needs a lifestyle modification as an adult, that may be in the form of daily strict physical activity, in the form of at least half an hour workout sessions a day, or 150 minutes a week are the recommendations. The girl needs to have a healthy, balanced diet, which consists of regular calorie restricted meals. You need to call the girl and routinely screen her for BMI and waist circumference, so that there's an ongoing method of finding out whether the child is going for PCOS. And you will know with the increasing adiposity, there's a higher chance of developing hyperandrogenism also. Always insist on a calorie restricted diet in the form of a low carbs and a low carbs and fat diet with a high protein in the diet. And lifestyle modifications are the main line of therapy for PCOS patients for at least 6 months. But if the girl does not respond, then you may need to add metformin as second line therapy. So regarding menstrual cycle regulation in a young child, in a young girl and adolescent, the first choice should be always progesterone withdrawal bleeds, or you can go for combined oral contraceptive pills. But if there's no improvement with the menstrual regularity with your contraceptive pills, then probably you may need to add metformin with or without progesterones, which may help. But the first line should be always progesterone withdrawal bleeds when there are irregular cycles. What about the use of combined OC pills? Because many mothers get worried when we prescribe oral contraceptives for adolescents. Low dose pills can be used. Do not go for high dose pills. But if the girl is between 12 to 16 years of age, do not use low dose contraceptive pills for a long period of time. That is, do not use the 21-day cycle the drug. Use it for only a short period, which may be just for 7 days. Or you can just give her 4 cycles a year for menstrual regularity. You need not give her like 12 cycles a year. You can reduce it to 4 cycles. But if she has attained more than 16 years of age, you can be given an adult dose, which can be prescribed for 21 days. But just for menstrual irregularity, it's oral contraceptive pills or progesterones. But when there's hirsutism, you need to add contraceptive pills, which will be the first line of therapy. So what is a problem which can happen with the use of contraceptive pills in an adolescent? The peak bone mass development occurs in an adolescent and a young adult. And when you use low dose estrogen containing combined oral contraceptive pill early in the teen years, there may be an affection of the bone mass, but there are studies which say it does not happen, but there are studies which say it can happen also. As there are no definitive conclusions regarding the effect of estrogen on the peak bone mass, it's better to restrict the contraceptive use for acne particularly, and not for menstrual irregularity. And if you can avoid it within 2 years of menarche on girls who are less than 14 years of age, unless it's definitely clinically warranted. And even when you use a low dose oral contraceptive pill in a girl who's less than 14, it's preferable that you use drospirenone or a drospirenone levomethnifolate combination, or a combination which has got norgestimate and norethindrone compared to the other progesterones. Regarding hirsutism in an adolescent, the management will be oral contraceptive pills as first line of therapy, along with direct hair removal methods. But if there are no improvement with contraceptive pills, or the pills are not tolerated by the girl, you can add spironolactone or finasteride. And finasteride and spironolactone should be stopped if the girl is become an adult and is planning a pregnancy. And when you're using a low dose oral contraceptive pill, it's better if you add an anti-androgen progesterone in the form of cyproterone, drospirenone or desogestrel, which are much better than the levonorgestrel, which is available in the standard drugs. So regarding hirsutism in the Indian condition, cyproterone acetate seems to be more beneficial than other progestogens. And when you're going for a hair removal technique for hirsutism, it's better that you give at least 6 months of oral contraceptive pills and stabilize the condition before you go for hair removal, because she may have hair growth if you have not given the drug therapy first and then going for a direct hair removal. Regarding acne, topical medication should be tried first, but if they are not effective, you need to give her oral contraceptives. And here also, it should be an anti-androgen progesterone in the form of cyproterone acetate, drospirenone, or desogestrel as a progestin component. And regarding obesity and hyperandrogenism, if a child is obese, has got hyperandrogenism and has got signs of insulin resistance also in the form of acne, in the form of acanthus nigricans, lifestyle modification will be the first line, and you need to add metformin now there are signs of insulin resistance. The alternative treatment in the form of acupuncture or complementary therapeutic options in the form of myoinositol, omega-3 fatty acids are not recommended at this point of time for the management of hyperandrogenism in young girls. And so this is the algorithm for hirsutism. First is lifestyle modification and cosmetic procedures. Suppose the girl is seeking fertility, you need not give any drugs for for hirsutism. But if she's not seeking fertility and there are no contraindications for ossiples, that should be the first line of therapy, and that should contain cyproterone, drospirenone, or a neutral progestogen. And if the results are unsatisfactory, you can add cyproterone, finasteride, or spironolactone. They are anti-androgen drugs. And suppose you need that she does not cannot use oral contraceptives because of some contraindications, it's better if you go for these anti-androgenism, but you need to secure contraception for her. So the psychological issues in PCOS in an adolescent is also extremely important, because there's a high rate of anxiety or depression in women and adolescents with PCOS, which has been proved without doubt. So you need to do a routine screening for depression in adolescents and women at the initial diagnosis. And do not try to use psychiatric agents for this depression, because it can worsen obesity, and it should be used with caution. But you can try cognitive behavioral therapy, which seems to be more beneficial for weight loss and symptoms of anxiety and depression. And this is very important. You need to make specific recommendations on regular weighing of the girl by herself, so that she has a control over how much she eats and how much she needs to control herself. And regarding the cosmetic and psychological issues which can happen in adolescent, we need to know that there's a potential negative psychosocial impact of a girl having clinical hyperandrogenism in the growing age. And that's why when a girl reports unwanted excess hair growth, but even though you don't feel that's not important, please give some importance to it, because she's feeling that it's important. And that is an important systematic review of quality of life in an adolescent with PCOS in their Human Reproduction Update of 2008. So this is one scale which is used to diagnose depression, and that is the patient health.
You are muted, madam. You are muted. Madam, your voice has...
Here?
Your voice has stopped coming.
Now it's okay, Kanchan?
Yes.
Yeah.
Okay. So I'll have, this is the last slide actually. Suppose there's a case scenario where there's a girl is 16 years old, menarche at age of 13. She's got irregular cycles since menarche. Her mother is a diabetic. On examination, she's got a BMI of 30. She's got acanthosis, she's got hirsutism, she's got acne. How are you going to talk to the girl when you have diagnosed this disease at the age of 16 years of age? There's something called a 7-step guide for patient counseling, and that was formulated by Foxy at the pioneering PCOS conclave by Dr. Nandita Palshekar at Hyderabad in March 2019. And what the consensus was, when you diagnose PCOS in a young girl, please gently break the diagnosis. Explain what PCOS is to her and to her mother and her father, whoever comes with her. Emphasize on the need for long-term management, because if she's got metabolic problems, even as an adolescent, she will need more acute management as an adult too. You need to counsel her on lifestyle modifications, diet and exercise. Explain to them different treatment options and emphasize on the need to adhere to therapy, because many of them fall out of therapy, and always ask her to look out for warning signs which may indicate much severe disease. So the Rotterdam Consensus of 2003 seems a little incomplete. So that's why in 2018, the International PCOS Evidence-Based Guideline came, and that specifically addressed the adolescent PCOS. Here, this criteria was recommended and endorsed based on unprecedented evidence synthesis and best practice methods by almost world-leading multidisciplinary clinicians and researchers across 37 societies from 71 countries, and they engage the consumer also, they engage the patient also before they came to the consensus, and they came out with specific recommendations for the adolescent. And here they said it's very challenging to diagnose PCOS as an adolescent, as menstrual irregularity and multifollicular ovaries are part of the normal pubertal physiology, and the application of adult criteria may result in over-diagnosis of PCOS, and you may actually cause a psychological impact by diagnosing PCOS when it's not there. And that's why they updated the criteria of 2003, and now they recommend applying oligo or anovulation and hyperandrogenism, and they've avoided the polycystic ovarian morphology for a diagnosis of PCOS in an adolescent. So you need to have oligo anovulation with hyperandrogenism before you say that the adolescent is going to have PCOS. So now they say do not use ultrasound criteria to diagnose this disease. Do not use anti-Mullerian hormone levels to diagnose this disease. It's not adequate. Insulin resistance is a key feature of PCOS, yet clinical measurements are not available at this point of time. So we need to check for the signs of clinical insulin resistance. And once diagnosed, please assess the girl and manage, which includes reproductive, metabolic, and psychological issues for the girl. Education, self-empowerment, multidisciplinary care, and lifestyle interventions are all needed for the prevention of management of excess weight, and that needs to be prioritized. You prioritize a lifestyle intervention, which is much more important than any drug for managing this condition. And you always screen for depression and anxiety symptoms and need to be assessed and managed. And health professionals should be aware of the other impacts on emotional well-being and quality of life when you diagnose PCOS in an adolescent. And regarding menstrual irregularity, the first line of drug will be progesterones, and combined oral contraceptive pills can be used when there's an additional feature of hyperandrogenism, but they have not specified any specific formulation, but they say always use low dose pills for an adolescent. And metformin needs to be added if you have got metabolic features in the girl. And what is the limitation of this consensus of 2018 is they're still not said what is the most accurate diagnostic approach for an adolescent. And it's not clear if you may not overdiagnose, but suppose you underdiagnose and you do not say tell a girl that she's polycystic ovarian disease, but she has got an underlying feature there, she may land up with a long-term complication, which can be very difficult to manage in an adult. So you need to balance a scale of not over-diagnosing or not underdiagnosing. So the long-term weight gain in an adolescent becomes very important at this juncture, because the long-term weight gain is a major health concern for any lady with PCOS, and it's a key feature, and it's a pathophysiological contributor to the severity of this disease. And then more than 60% of the women with PCOS are above a healthy body mass index, and which exacerbates the metabolic, reproductive, and psychological features of PCOS. That's why weight is very, very important in an adolescent when you're managing in the clinic. So the balance in diagnosis needs to be made. Suppose you overdiagnose under the original diagnostic criteria, it may cause unnecessary psychological distress, financial and treatment burden, but you cannot afford to underdiagnose or delay diagnosis also, because it can have long-term effects on the health of the adolescent. So be very careful when you manage an adolescent with PCOS. But the key driver of severity has been identified by this consensus, and that is you need both hyperandrogenism and oligo or anovulation to identify the adolescent most at risk of excessive weight gain, because the weight gain is a key driver of PCOS severity, and this group has got a higher body mass index, should be targeted for early lifestyle intervention and prevention of the disease. So you have an at-risk category according to this consensus, that is, they do not meet the diagnostic criteria of PCOS, but they've got some symptoms which may make you suspect, and that's why this group you put it as at risk. You call them for regular re-evaluation, and in every regular evaluation you ask them for the menstrual cycles, and usually at 3 years post-menarche you have to be extremely careful with these girls, and always screen for anxiety and depression, because you can put a diagnosis and send her home, which is going to be totally demoralized if she's not going to be managed at the psychological level also. That's why this at-risk category is very, very important in a PCOS in the adolescent period. I'd like to thank Kanchan for the opportunity. Thank you so much.
Thank you very much. This was a very nice, crisp, and very clear-cut message you have given, ma'am. Just because Dr. J. Kanan is senior most, she can comment a bit on it. You have very well told about the Histidism, lifestyle management, about the 7-step, how to counsel the patient, what is the importance of it. And now the ultrasound diagnosis is not only the whole soul on which we diagnose the PCOS. There are so many other criteria. Old Rotterdam criteria is not now no more valid, but new one is there, and all the valid points just to treat insulin resistance is the one of the most important thing in it, and all the very nice factors that you have told in total. And Dr. Jem Kanan, ma'am,
Yes.
you comment?
I would like, as Charmila made it very clear, break the news, because nowadays everybody is educated. What is PCOM? What is PCOD? And then PCOS.
Yes.
PCOM is only morphology by ultrasound, not a problem. PCOD is a one which has got the symptomatic problems of polycystic ovary. The polycystic ovarian syndrome is the one which Charmila has very clearly made out what should be the PCOS in adolescent. It is not only 2 out of 3 of Rotterdam, it is everything of Rotterdam, and rather it has been put as 5 criteria by the Canadian Society also. Soon we will be getting it, and she has correctly, aptly pointed out all the problems regarding even this low dose pill and the progesterone that has to be added. She has made it very clear. Ciproteran is the one in Indian scenario. I have been using it for quite some time. Even in South Africa, I was asked to install the drug by the Cipla company. I was taken to Africa to install it, and they asked me, what is your experience on this Ciproteran? I gave them all the details, and they were very happy with it, and the market has picked up very nice. Congratulate Charmila for her excellent lecture.
Thank you, ma'am. Thank you.
Thank you, ma'am. My president, Dr. Usha Goenka, is there. She
Yes,
has
good
took
evening.
time from the surgery, and she is a chairperson in this
Hello,
particular
Dr.
session.
Sharmila.
Good evening, ma'am. How are you,
I am
ma'am?
very sorry, Dr. Kanan, joined late. because of the
Nice to
emergency.
see you. Nice to see
Good
you all.
evening, ma'am. Good evening.
Good evening.
Yours was a wonderful presentation, Dr. Sharmila.
Thank you, ma'am.
Congratulations.
Thank you so
And
much, ma'am.
you are very true. There's physical activity, diet, and mental status is very important in controlling PCOD. The moment we break the news of PCOS, whole family becomes disturbed, then we should give the news with a pinch of salt. That's very important. And we should motivate them for physical activity. That's the utmost important thing. Thank you so much.
Thank you, ma'am. Thank you.
Okay, thank you so much. Very brilliant speaker and all the chairpersons, and J.M. Kanan ma'am for your wonderful comments. Now coming on the second session.
Madam, good evening, Madam. Shantrani is here.
Yeah,
Madam,
Dr.
able to-
Shanti Rani is there.
Yeah.
So the floor is yours. Mic is given to you, ma'am.
Yes, sorry, Madam. My internet connection is little unstable because of heavy rains at Thane. First of all, at the outset, I thank you for giving me the opportunity to be the MOC for this event. And really, I am blessed to be here and to share the screen with the great people like J.M. Kanan, Madam, Revati ma'am, and Asha Madam. And I thank you for the opportunity, and congratulations, Charmila Madam, for your success in your election.
Thank you,
And now, stepping up to the next session, I like to invite the chairperson for the session, Dr. J Lakshmi. Can I see? Can I see? Madam is a consultant and medical director of Mangalam Hospital, multi-speciality hospital in Chennai, Tamil Nadu. And she had around 28 years of experience in OBGN, a trained infertility specialist. And she is a winner of poster presentation and psychological evaluation of infertile couples in ISA 2018. Her special interest is in ultrasound and infertility. Next chairperson is Dr. Purnima. She is the Secretary of E-Road Society. Welcome you, ma'am.
Thank you, ma'am.
Yeah, Madam is she had various certification. She had an ultrasound from Sono Scans and infertility from Asha Rao Ma'am Hospital, Histoscopy from Women's Center, Coimbatore. And she is present time the Secretary of E-Road. I welcome you, ma'am.
Welcome, ma'am.
I want J Lakshmi Madam to introduce the speaker, the senior most position, role model for so many persons of Tamil Nadu, like youngsters like us. And Madam told that she will not come for without any preparation for her talk. Just an inspiring word from her today. Madam, with that, I like Vijay Lakshmi Madam to introduce our respectful J Kannan Madam.
And thank you, Madam. Thank you, all of you, for giving me this opportunity. First of all, thank you. And really, again, it's a great pleasure to introduce Madam once again. Why I'm telling once again is because recently only we had been selected. Madam has been given award from the IMA in Thambram as a best lady doctor for this year. So we were one of the members there to give her. So we are very happy again, Madam, to introduce you here again. Madam is one of the best. Yeah, she's one of the managing director. She's a director of the Garbha Rakshambika Fertility Center from Chennai and Tiruchi. As I said, Madam had got many awards during her MBBS period, about 13 awards. And during her MD period also, she's got many awards. And she was the first, she got a President of India medal for outstanding performance in MBBS. And she was the one of the Indian to get to be Distinguished Service Medal from RCOG 2019. That's one of the best thing from South India also. And then she's presented many papers and awards in many scientific papers. She's a Best Life Achievement Award in 2019, and then in the Tamil Nadu Medical University, she has been given the Best Achievement Award in 2011. She's written many books, and in which that Kulandai Peru Maruthuvam for the first year in 1998 was been awarded by the government of Tamil Nadu, and then she has been the book award for Magaperu Sangamam, one of the books which has been presented for scientific papers also she has been given, and then she's one of the international conferences she has been attending and as a faculty and delegate. So a warm welcome, ma'am. And really, it's a great pleasure to introduce you again. Thank you, ma'am. It's your
warm welcome, ma'am. I really been so much impressed by your clear concept and the way you talk and way you bless. Thank you so much, madam. Welcome. Welcome.
Thank you. Thank you. Thank you very much. Thank you, Vijay, for giving the excellent details about me. Can I share my screen?
Yes, ma'am.
Yeah. So the topic which I took, you know what happened when Kanchan Sharma called me and told me my laptop was totally down. I was worried, what am I going to do? That is because I have put in a original software which was getting converted into this thing, latest the version of 11, Windows 11. And I really broke down. Then Charmila helped me, sent me somebody, and here it is my slides for everybody. Now, let me go in the reverse and tell you, this is a case where you have opened the abdomen and you are not able to deliver the baby. That is what is called uterus holds the baby. I am very clear in what I am saying. I am not looking at her heart. I am not looking at her pulse. I am not looking at her blood pressure. I am not looking at it. Because I know well I have taken a straightforward case for cesarean section with the indication in which I was taken up by surprise by some of these points. We never diagnose glabella by any means. Brow presentation. Face also can be sometimes goes unfaced. Unless you have done a transperineal ultrasound, it is very difficult for you to ask for a face presentation diagnosis. How many of us are sending a patient in labor or just before delivery, 40 weeks, for ultrasound to diagnose the type of vertex presentation. We only diagnose cephalic, breech, transverse line. I hope I am clear about it. And then in the breech, we always look for breech and say it is indicated for cesarean. How many of us look for a flexed breech, extended breech, and complicated breech? Please stay with me and look at it. Then you have taken up a second stage cesarean, know very well that it is a occipital posterior, deep transverse arrest, delayed labor. How many of us can know at that time it is complicated by a compound presentation, a hand presentation, or anything? We don't know. We think that we are delivering a patient with ruptured membranes. But she has drained all the liquor out and she has come as a severe oligohydramnios. How many of us in labor do an ultrasound and find out the pocket of amniotic fluid? Preterm delivery, everybody knows it is a difficult case. And a floating head at term as an ideal indication for cesarean section. Robson's classification again comes into it, where the Robson one looks for it. So with all these things knowing well, we are going for it. Now, let me give you the tips, because I'm not going to say why the baby is being held up. Let me give. The first thing I would like to say is that the patient first, position yourself properly and get yourself diagnosed appropriately. You stand correctly, operating surgeon. And the last point I have put, please note down also, I will come to it. Then just elevate the fetal head to the level of the uterine incision. Just push the baby with your hand. And always put your hand, rotate the occiput anteriorly so that the distance comes down. Reduce the lower lip. You have done an incision, you push down the lower lip, automatically the baby will eject out. Have a silent patient assistant, middling less assistant. An assistant which also tries to put her hand is the one which adds to the complication of cesarean section. Then come to the next one. We all have all these things, U incision, V incision, all this Fanon seal, all those things are there. But I would prefer to have a, if you think that you may land in difficulty, a partial Maillard incision. Please cut a small portion of the muscle, because there is nothing wrong in cutting the muscle, because the muscle is going to help you better. And the patient is not going to have the 10th cesarean as it has been put last year from South Africa, or the maximum cesarean which has been done in USA, 11 cesareans. So have a wide uterine incision also. No U, no V. Don't be worried about uterine artery at the beginning of the cesarean itself. Okay, now we have opened the abdomen. We find a stretched bladder, a distended lower uterine segment, and on the small incision, the shoulder ejects out. We expected to see black hair, but we see the pink shoulder. Then we also see a deflected head with the neck portion seen at the time of surgery. Quickly plan your these things. Never think about anything else. What is your choice with your experience is the next thing that you have to think of. So what are the methods? I'm not going to talk about it. Push, pull, bimanual, Patwardhan, disimpaction system, use of instruments, because Kanchan has given me only 10 to 12 minutes. Okay, now the great difficulty you get, the great glory you get, because after finishing that work, you feel so happy that you have done the best thing in the world. Nobody else can do it also. So now the abdominovaginal delivery is the hallmark for a deeply engaged head, where two people, not the assistant standing on the opposite side, the third person comes down and that person is going to hold the fetal head and push it up. At this position, kindly think of what you do in shoulder dystocia. You put the patient in a Brand Andrews techniques with all the wide legs. The same wide legs should come in. So at that time, the surgeon should know that she has to shrink herself, her tummy, so that she is able to support this person. Then what you do, you have to flex your wrist. Never have a straight wrist and try to foot your body like that. So flexion and have your hands in the pronation, not in the, not like this to deliver the baby, but to go like this. Automatically the baby comes up with your hand, and see how I have put the hand. Then never think that you are not able to deliver the head. Ask the anesthetist to give pressure on the fundus, because your fingers have not gone down. You see, your fingers are there at the pubic ramus. It has to go and touch the baby, they say, frontal region. So it has to set the breath. So like this, you have to go, wait, do not allow the anesthetist to push the baby and give more problems. And secondly, whenever the anesthetist is giving a push, he always gives a push right at the Ziphy sternum. So what happens? The baby is always a LOA or ROP mostly. So what happens? Because the push is given in the center, the side goes on the side, you are not able to get the baby. Always give the push if the baby is LOE on the left side, with ask him to do it with the left hand. If the baby is ROP, ask him to push it from the right hand on the right side. So not with both hands in the middle, left hand like this in LOA, right hand like this in ROP. That helps you very well. Otherwise, even if he is not giving, your own hand going this way and going this way can help better. If you are used to a vacuum cup, if there is a difficulty, you can do it like that. Sujata, the always picture is there, and she has beautifully shown it. All these Patwardhan techniques are known to you very well. I am not going to discuss this because you are all adept with it. So the assistant from the vagina only can push it. What I said in the beginning, a silent assistant on the opposite side. Until the baby is delivered, she has to keep her hand like this in her chest. And the minute the baby's head is coming out, then she can put the suction, she can cut the clamp, all those things. Please ask her not to do anything before that. So compared to the traditional abdominal pelvic deliveries and the Patwardhan's method, the latest one on breech extraction, reversed breech extraction, proposed by Arul Kumaran and Fong in the year 1997, 25 years ago, is the best method which I am using till date. The minute you open the abdomen, you have your accoucheuse hand, that is obstetric hand, hold like this, go into the fundus, hold the fetus. At that time, when you hold the fetus, do not pull down right. You know that whether the head is like this or like this. So you go at the direction at which the baby is there and push out your hand. Automatically, the baby will come when you are parallel to the axis of the baby. And this does not give extension of tears, and it is going to be very clear. Now comes the floating head, which we have taken up as Robson's classification. In these cases, it is first the lateral support by both the surgeon and assistant. So the surgeon puts a hand on the right side, and the assistant puts a hand on the left side of the uterus and keeps the uterus like this. Don't allow it to move on the sides. That is the first thing. The second thing is amniotomy. Wait for all the liquor to go out, and automatically you can take 3 minutes to deliver the baby. Spend these 2 minutes on waiting to deliver the baby. Automatically the engagement of the head will occur, and a little fundal pressure, as I said, on the left side or on the right side, will allow the baby to come down on its own. Extremely low birth weight, if you are going to deliver, you are very sure that there is no lower segment. There is no extension of uterine incision. Uterine artery involvement is not seen at all. It's a thick myometrium. If at all you have is a bleeding from the uterine wound, which you have to keep it very clear. And always a direct transverse incision on the uterus is very, very important, because there is no uterine segment, lower uterine segment at all. All this vacuum and other things are not available when you do an emergency work. And if you are used to it, you can keep it very well, as Sujata Dalvi has done it. Otherwise, don't do it. all the cesarean head deliveries and all with forceps is getting outdated in the present scenario. So in summary, be safe with all the records for cesarean section. Be sure of what you are doing. Be swift in your surgery. Be sound in your clinical and surgical knowledge. Do the surgery relentlessly and bloodless surgery. Obstetrician should have a lady's finger hand, lion's heart, eagle's eyes, and a good hand dexterity at any age of yours. Thank you very much for your patient hearing.
Excellent session. This was a wonderful, crisp, and clear message.
Very nice.
Very nice, madam. We have gone back to our student life. Very nice to hear the lecture again. Very nice.
For every cesarean patient, we are the first, that is the first cesarean in our life. What tension we have at every time should be there with every delivery. I should never think I am a senior most person.
Very true.
That is very, very important. They should be the humblest person at the time of delivering the baby.
Very true, ma'am.
Very true.
Not to get to panic.
Chairperson's comment.
Very nice presentation, ma'am, and it's really an honor to share the screen with you. Thank you so much, ma'am. It was a very wonderful, neat, clean presentation, very short, and all the points has to be taken home. And it was like attending a postgrad class again. Thank you so much, ma'am.
I am still a teacher, Purnima. I still teach.
Yes,
Even today, when I was doing a polyp removal, one student has come from a private medical college where she has not even put a speculum. So I taught her how to put a speculum for a speculum examination. Today at 2 o'clock, I was doing it.
Thank you so much, ma'am. It's really great, ma'am. Thank you.
Thank you, madam. Thank you.
I want to be your student always.
Thank
Such
you.
a wonderful
Yes, ma'am.
teacher are you.
Thank you. Thank you.
Great.
Thank you, madam, for all the tips and tricks. Thank you so much, madam.
Chandrani will accept these tricks because
Yeah,
she is
madam.
every day in and day out doing cesarean because she is the
Every day, second stage cesarean, we are doing a lot.
Yeah, I know. That is a very important because second stage we can't give it to the postgraduates.
Yeah.
I always stand by with my this thing daughter-in-law who is 15 years in experience, but still I always stand by her.
Thank you, madam.
So
Thank
nice.
you for that.
Thank you.
Thank you always to see your enthusiasm and really inspire us, madam. Lot. Thank you. Thank you so much, madam.
See, because all this pronation, supination, we don't hear about it, We always think that we put our hand like this, but we have to put our hand like this. Otherwise, the hand will not do. Yeah, thank you. Thank you, Purnima. Thank you, Shanti. Thank you, J Lakshmi.
Thank you, madam. Thank you,
Kanchan,
madam.
everybody.
Thank you.
Thank you.
Thank you, ma'am.
Thank you for being with us.
Thank you.
Madam, can we step on to the next session?
Yes, ma'am.
Yeah. The next session is thin endometrium. The speaker is Dr. Kanjan Sharma. And can I invite the chairpersons, Dr. Rekha Rajesh? This madam is a director of Vijay Hospital and director of Vijay Shruti Fertility Center, director of Martava Fertility Centers, founder secretary of OBGYN Society Krishnagiri. She is a member ISAR and member IFS, member PCOS Society of India, member of IMS. And next chairperson is Saran Kumar, Dr. Saravan Kumar. He is secretary OBGYN Society of Salem. And he is MBBS from WIMS Bellary and MD from Madras Medical College, professor and HOD of Annapurna Medical College, consultant of Mallar Maternity Hospital, Salem, initiated and trained young doctors in operative laparoscopy in Annapurna Medical College, and his field of interest is high-risk obstetrics and gynae. I request Rekha Rajesh madam to introduce Kanjan Sharma madam. Madam is there? Rekha madam is there? Madam, I am audible?
Yes, you are audible.
I think
Yes,
Rekha madam is not. Rekha madam is there, no?
Yes, ma'am.
Madam, can you introduce Kanjan Sharma ma'am? Shield people, can we have Kanjan Sharma ma'am? CV.
Sure, ma'am. Sure.
Saravanan sir is there? Kumar sir is there?
I think she was there. He was there already.
Then I introduce Madam. Madam is actually, she's the Secretary of Kanpur Obstetric Gynec Society 2021 to 23 and Director and Chief Consultant of Akash IVF Center Kanpur, ART Specialist, Laparoscopist and Colposcopist. And Madam is a candidate for Chairperson, Study of the Female Breast Committee. I wish you all the success in your upcoming elections, Madam. And
thank you.
I request you to deliver your talk.
Thank you, ma'am. May I share my screen?
Yes, ma'am.
My screen is visible.
Yes, ma'am.
Am I audible?
Yes, ma'am.
So, thank you. I am Dr. Kanchan Sharma. First of all, my sincere regards and thanks to all the society of the Tamil Nadu and the great persons who have given me chance to speak in between you. My thanks and gratitude to our chief guest, Dr. Ramani Devi, past Vice President, Foxy, Dr. J Lakshmi, Chandrasekhar, President. She is President TNFOG. Sincere thanks to guest of honors, Dr. Vidya Dobi, President-elect Kesoji, Dr. Revti, Janki Raman, past Vice President, Foxy, Dr. Asha Rao, Chairperson Endometriosis Committee, Foxy, and thanks to Speaker Dr. Charmila and Chairperson Dr. Usha Goenka, Ma'am, Dr. Malini, Karur Secretary, thanks to Speaker Dr. J Kanan, past Vice President, Chairperson Dr. S. J Lakshmi, Dr. Purnima, Secretary of Erode. Speaker, next speaker is myself, and thanks to all the chairpersons of this society, and thanks to moderators and all the panelists who have joined today's session and gave me chance. Hard fact is about the thin endometrium is healthy seed is not enough to get a healthy sapling unless it grows on the fertile soil. Similarly, healthy embryos need receptive endometrium for the successful implantation. The endometrium that is derived from the mucosal lining of the fused Mullerian duct. It is essential for the reproduction and may be one of the most complex tissues in the human body. It is always changing, responding to the cyclical pattern of the estrogen and the progesterone of the ovarian menstrual cycle, and to a complex interplay amongst its autocrine and the paracrine factor. So coming on the anatomy, upper 2/3 is the functionalis layer and lower 1/3 is the basalis layer. Functionalis layer prepares for the implantation of the blastocyst, and therefore it is the site of the proliferation, secretion, and the degeneration. Basalis layer that provides the regenerative endometrium following the menstrual loss of the functionalis. So thin endometrium is a challenging occurrence in ART. If we see the IVF key steps, that is, we take the sperm and egg and fertilize in vitro, and then make the embryo blastocyst stage and put it in again endometrial cavity. So endometrial cavity, endometrium is very important for all the ART specialists. What are the factors responsible for IVF failure? If we see, endometrium receptivity is one of the major factor that governs our IVF success. Robert Edward, he was the father of IVF, once wrote, endometrium is the last barrier to progress in the assisted reproductive technology. So endometrial receptivity is very important, and this is governed by its thickness, its pattern, its blood flow to the endometrium, and the subendometrial zone, and its volume. Volume is very important. So this diagram of the ultrasound that shows the thickness, blood flow, and the volume endometrium is divided in the 4 zones. Good vascularity in zone 3/4 in relation to uterine lumen suggests good endometrial receptivity. For that, estrogen and progesterone receptors are very important. So endometrial thickness, we say thin. How thin is the thin? The thin endometrium is often defined in ART practice as endometrial thickness less than 7 or 8 mm is the thin endometrium. We have to counsel our patient for the thin endometrium. This is very important step. In fresh IVF embryo transfer cycle, patient should be counseled that endometrial thickness, your endometrial thickness is 8 mm or less than 8 mm. So look, you may have some negative effect and maybe a problem in conceiving, because the embryo implantation may be a bit difficult. Now coming on how to measure the endometrial thickness. Ultrasound is the ideal non-invasive tool to evaluate the endometrium. Endometrium should be measured with an empty bladder using a transvaginal probe. Transducer is physically closer to endometrium with a transvaginal probe and uses a high frequency 5 to 8 megahertz compared with the transabdominal assessment. Now, how to measure? Endometrium should be measured in the sagittal plane or the long axis. The measurement is of the thickest endometrial area, echogenic area, as shown in this diagram, from one stratum basalis endometrium interface across the endometrial canal to the other stratum basalis interface. Surrounding in the inner myometrial lucency is not included in this measurement. Uterine physiology also provides a significant potential source of bias. This is very important. You should see what are the bias. Uterine contractions can cause changes in the endometrial thickness of up to 3 to 4 millimeter due to changes in the myometrium and the subendometrium. Most patients have multiple contractions per minute. So periodicity tend to differ with the stage of cycle. Circulating estradiol and progesterone concentration and the endometrium thickness pattern is very important. So factors that limit the accuracy of the endometrial measurements are fibroid, adenomyosis, polyp, uterine orientation, previous surgeries, uterine contractions, ultrasound machine quality, inter-observer and intra-observer variability, and patient intolerance. So thinning of endometrium, usually that is a usual in after 40 years, low estrogen, inadequate blood flow, and bunch of other reasons who reduce the blood supply are there. Sedentary lifestyle, malposition of the uterus, fibroid of the uterus, all reduce the blood flow. Many times there is a surgery like uterine fibroid embolization that block the blood supply and cause the thinning of the endometrium. Arterial constriction of the uterus is very important. So thin endometrium may be created by the injury, by the surgery, trauma or infection. Infection like PID may be there. There may be scarring of the endometrial lining. After dilatation and curettage, may be excess damage of the endometrium in many cases. In scar tissue and the adhesion damage may develop. So these are the different causes. In short, we can say there may be iatrogenic causes, may be inflammatory, and other causes like low estrogen level, use of CC, prolonged use of progesterone and COCs, inadequate blood flow, and there are a lot many systemic causes, hypertension, smoking, diabetes, and many idiopathic causes. So non-receptive endometrium is one of the major cause of ART failure. So we infertility persons have to consider it. We have to see about the endometrial thickness, endometrial volume, echogenicity, and Doppler. So what are the objective for the management? These are, first of all, we have to treat the cause. If there is infection, treat it. And earlier options were hormonal adjustment, pentoxifylline and tocopherol, low dose aspirin, acupuncture, L-arginine even was given, nitroglycerin patch, vaginal sildenafil, GCSF, stem cell therapy, endometrial scratch was, and PRP plasma, as I am doing at my clinic in many of the patients. Treatment strategy for anti-estrogenic effect of clomiphene, We may use letrozole and tamoxifen in these cases. Many times we have to give the hormonal adjustment. Estrogen, oral, intravaginal, and transdermal patches are being given in many of the patients. SCG priming was also a concept which they were doing. Pentoxifylline and tocopherol are very important agents. They are increasing the blood flow. Low dose of aspirin have also been used, and their role is still debatable. L-arginine and nitric oxide donor relaxes the vascular smooth muscle of the endometrium and may increase the blood flow. Sildenafil citrate that increases the blood flow and the endometrial thickness. Many persons are using still. The vaginal pessaries are also being used in many cases. GCSF we have used a lot, but still I find this PRP plasma to be much successful as at my center. This is my picture. I'm going in very short. This is at my center. I'm taking the PRP tubes in which I take 10 ml of the patient's blood and I centrifuge at 3000 RPM for 10 minutes. And after 10 minutes in the centrifuge tube, I get these 3 layers. First of all, lower is the red blood and platelet poor plasma is upper one, and mid one is platelet rich plasma. I throw upper 3/4 platelet poor plasma and use mid one platelet rich plasma. That is being introduced inside the uterine cavity if I am doing ART and I am seeing the endometrial thickness is less in the previous cycle. In this cycle, on 11th day, I'm giving this PRP rich plasma, and I got very good results. Many times I have to repeat after 48 hours. Many of the patients who got previous IVF failure because of the thin endometrium being referred to me, and I have used this PRP plasma, and thank God they got success and very good result, and they delivered a full-term child. So in summary, the thin endometrium affects the success outcome. Receptive endometrium with a proper endometrial development plays an important role in embryo implantation. Vaginal sildenafil may be used. Stem cell therapy is very successful. PRP as we are using. Thank you very much for giving me chance, and my humble request just to bless me for my future candidature. Thank you for giving me chance to speak.
Dr. Kanchan, that was a very good presentation and very brief and crisp with a lot of take-home points. Thin endometrium is a nightmare for a lot of fertility specialists, and I think all of us are struggling with many patients. You are given a lot of channels of treatment, and here lifestyle modifications, nutrition, exercise also plays a very important role for improving the endometrial receptivity. There are a lot of papers where they say yoga and exercise has also improved the endometrial preparing activity for all of us. And in patients, there have been papers presented regarding for lifestyle modifications for preparing the endometrium. And in other alternative methods, they have used acupuncture, and then they have used supplements which are very important, like tocopherol, where omega-3 fatty acids are used. So I think probably we should also start with additive therapies with nutrition and exercise being a base of the treatment, along with our estrogen and ecosprin and other tablets. Thank you, Dr. Kanchan.
Thank you. Thank you for the nice.
Dr. Saravana Kumar is there, no? Sarah was there on the screen.
He was there. Yeah. Dr. Saravana Kumar. I saw him there.
Yeah.
Dr. J Kanan, madam.
Saravana Kumar sir is there, or otherwise we can move on to the next session. I was actually seeing his name on the.
Thank you, and all the best, Dr. Kanchan. Let us all work together for the society.
Thank you so much. Thank you so much. Thank you so much.
Thank you, madam. Thank you, Rita madam, for your comments too. So we'll move on to the next session. It is thrombocytopenia with pregnancy. The speaker is Dr. T. Vichitra, President of Coimbatore OBGYN Society. For this session, we are having 3 chairpersons. Dr. Mary Genova, she is the President of Virudhunagar OBGYN Society.
Welcome, ma'am.
Madam did her MBBS and DGO in Madurai Medical College, Madurai. And she is the Medical Director of Joseph Hospital. And their area of special interest is high-risk obstetrics and reproductive medicine. The next speaker is Dr. Tiba Mohandan. Madam is the Senior Consultant OBGYN and Endoscopic Surgeon in Best Care Hospital Private Limited, Trichy. She is graduated from Government Kilpack Medical College and did her PG from Government Stanley Medical College. Current Secretary of Trichy OBGYN Society. She is the Executive Committee member of TNFOG and been a faculty in many international, national, regional and conferences. Her area of interest is infertility, endoscopic surgery and high-risk obstetrics, urogynecology. Our next chairperson, Dr. Jyoti Sundaram. She is the President of Madurai OBGYN Society, Professor of Department of OBGYN of Madurai Medical College, and she is the Senior Consultant of Mitra Hospital, Madurai, at present President of Madurai OBGYN Society, member of MTP Committee, FOXY, UGPG teacher for more than 20 years, UGPG and DNP examiner, 4 times Best Doctor Award from District Collector and from IMA. Her field of interest is high-risk obstetrics. May I request Mary Genova ma'am to introduce our beloved Chitra ma'am. Madam is not there. Mary Genova madam is there. Deepa madam is there.
So I will introduce her.
Okay, madam. Can you have the CV of Dr. Chitra?
Yeah, I'll
testing for Medical Disorder Committee. All the best for her.
Thank you, ma'am. Thank you so much.
All the best, madam.
Thank you.
Madam, can you introduce Dr. Chitra ma'am?
Dr. Chitra ma'am is a professor and unit chief of the Obstetrics and Gynae Society. She is PSC Institute of Medical Science, Coimbatore, Tamil Nadu. And she is affiliated to, she is a president of COVI Society, scientific committee member of UVA-FOXY, and special interest in the urogynae, high risk pregnancy, and she is honored by teaching excellence. And most important, our good wishes for her future endeavor. Ma'am, the stage is yours.
Can I share my screen, ma'am?
Yes, ma'am.
At the outset, let me thank Dr. Kanchan for this wonderful meeting. It only shows her perseverance. With just a few days for the election, and in spite of it, she's taken so much of efforts to involve all the people from Tamil Nadu. Hats off, madam, and congratulations, and wish you all the very, very best.
Thank
I
you.
really appreciate all the enthusiasm that you have.
Thank you so much.
And best wishes, ma'am. She's contesting. So please, all of us, let's work together like how they said.
Thank you.
So my topic is thrombocytopenia in pregnancy. So what I'm going to do is, over the next few minutes, I'll be talking about the normal physiology and pathogenesis of platelets. What is the etiology of thrombocytopenia that we come across? How will we diagnose and how we're going to manage? I will only be dealing with the very common day-to-day things that we see routinely. Now, platelets are normally produced by megakaryocytes, and roughly around 35,000 to 50,000 platelets are being produced every day. But surprisingly, the platelets will be, their survival rate is only for 8 to 10 days. It's unlike your RBCs, which live for around 21 days. This is only for 8 to 20 days. And normal platelet count is roughly around 1.5 to 4.5 lakhs. So you can't give platelets very early because the lifespan is very less. So you must be able to give platelets only at the correct time. That is the importance of knowing how long the platelets survive. Now, low platelets, typically they will present with mucosal bleed. You can have patients can present with ecchymosis, purpuric spots, bleeding from the gums, etc. Unlike where you have an hemorrhage because of trauma, where you think of other clotting disorders. But whenever there is a mucosal bleed, you tend to think of low platelets, and that might be giving rise to this. Now, what is the definition of thrombocytopenia? Any patient who has a platelet count less than 1.5 lakhs during pregnancy is said to have thrombocytopenia. And generally, as the pregnancy advances, the platelet count becomes less and less. So nearing term, they've done various studies and seen that the platelet count may be as low as it can roughly be a mean around 2.1 lakh, and it can even be as low as 1.1 lakh. That is said to be normal during pregnancy. So this is a general important cause of thrombocytopenia in pregnancy. If you just see the topmost in the list is gestational thrombocytopenia. As the name goes by, any platelet count being low only during gestation, that is known as gestational thrombocytopenia. Second one would be all hypertensive disorders in pregnancy, including your preeclampsia, HELLP syndrome, etc. And the third one would be your primary ITP, either primary ITP or secondary ITP. And then would come your Apla syndrome, SLE, and other infections. And of course, not to forget the drug-induced thrombocytopenia, because we handle so many drugs, we should know which drug is causing thrombocytopenia. Now, this is roughly the causes, because there are quite a few causes, but we should know what is important. In first trimester, whenever you say a person who has a low platelets, you must immediately think of ITP. Second trimester also, ITP is very important, but there also towards the end, you could have a gestational thrombocytopenia. In the third trimester, when you find a person with low platelets and she's been having normal platelets in the first and the second trimester, you think of gestational thrombocytopenia. The other things also you must entertain. Is it a hypertensive disorders in pregnancy? Is it TTPS? Is it HUS? Or is it, gestational thrombocytopenia? Other things also must be considered. But the first trimester is always an ITP. Second trimester also an ITP. Second and third, you will think of gestational thrombocytopenia. Now, this is a rough study which showed what is the scenario in the Indian situation. And there again, everywhere they say the gestational thrombocytopenia is the most important, followed by your preeclampsia. Now, this is very important slide because all of us must know what are the drugs which are causing thrombocytopenia. The antibodies that we commonly use, ampicillin, penicillin, are very notorious for causing thrombocytopenia. Diuretics, we don't use furosemide and thiazide. But and the third one is analgesics, indomethacin. We only use it for a very short time, especially when a person has preterm labor and in the event of a hydramnios. You might use it to reduce both, in which case you might be giving indomethacin. So you must be on the watch out whenever you give NSAIDs. And anticonvulsants, which is very common, phenytoin, your carbamazepine, and valproate. Whenever a person is on those drugs, you might be developing thrombocytopenia. That is another important thing. Suppose your platelet count is normal or it's less than normal, and then the report says clumps of platelets are seen. That means it's a pseudo thrombocytopenia. Maybe in reality the count is normal, but because of clumping of the platelets, apparently the error is. There's the report saying low platelets, but in reality it's only because of clumping, and that is known as pseudo thrombocytopenia. So you must always go back and see your CBC report. If the CBC report says clumping of platelets is seen, then that could be a case of pseudo thrombocytopenia where you don't have to really worry a lot. Now, gestational thrombocytopenia, just to touch upon it, 5 to 11% of all pregnancies have gestational thrombocytopenia. The salient features are it can occur in the second and third trimester, and as the name goes by, it is only present during gestation, and as soon as the pregnancy is over, it disappears. So it's normal in between pregnancy, and generally the counts do not go less than 75,000. It's on an average around 75 to 1 lakh. These patients are generally asymptomatic, and after delivery, the platelets will come back to normal. And most important is, whenever you have a low platelets in pregnancy, you must be worried, is the baby also going to develop low platelets and will the baby be affected? But however, in gestational thrombocytopenia, babies will not be affected. There is no instance of neonatal thrombocytopenia. Now, how will we manage gestational thrombocytopenia? In fact, the only thing that you have to do is you have to monitor serially the platelet counts and see what is the cutoff, at what level is the platelet count coming to. It should not fall below 50,000 during delivery. So you must see that the platelet count is around that. We will come to that management later, but generally only a serial monitoring of platelet count is all that is necessary. There is no need for any intervention. So every month, whenever the patient comes, you have to check the platelet counts. Next, we move on to preeclampsia. Preeclampsia, I know all of us know, we know about HELP syndrome. Preeclampsia is very, very common. 5 to 20% of all patients we see with preeclampsia, and many of them will have HELP. So whenever there is HELP, the first thing that might occur is platelets. In fact, they say even before the other symptoms of preeclampsia can occur, before the other symptoms, etc., can occur, some patients might have only a low platelets. So whenever you see a patient having low platelets, you must keep in mind, is this particular person going to develop a HELP syndrome? That is what we should really think of. Now, the other things in microangiopathy, DIC, HELP syndrome, TTP, and HES, all these conditions also can develop thrombocytopenia. So it's important that we try to identify, is this particular person having thrombocytopenia because of HELP, or is it transient TTP of pregnancy, or is it hemolytic uremic syndrome, or is it an acute fatty liver of pregnancy? This chart will tell you all. Because whenever it's very, very confusing actually, whenever you see a person having preeclampsia and she also has thrombocytopenia, you normally tend to think of HELP. But don't forget that there could be other factors like acute fatty liver of pregnancy, etc., which mimic the same way. So it's only by a battery of investigation that we will be able to find out what exactly it is. Then what is this ITP? This ITP is a condition where there are some antibodies formed against the platelets, and as a result, the platelets will come down drastically. So there is really no signs and symptoms of ITP, but it's mainly a disease of exclusion. You rule out all the other conditions, and if it doesn't fit into anything else, then you think of ITP. And especially in the first trimester, whenever you see a low platelets, you will definitely always consider ITP as one differential diagnosis. It is not so very uncommon. 1 in 1,000 to 1 in 10,000 people will be having ITP. And again, it could be primary ITP or it could be maternal ITP. Now, there's a caution about this ITP because here what happens is the antibodies which are present against these platelets. So these antibodies are IgG, and they will cross the placenta and get into the fetus, and they can cause neonatal thrombocytopenia. So you should be very careful when you deal with a person with ITP, because the babies also will tend to have a low platelets. That is the difference between ITP and gestational thrombocytopenia. But however, the complication in the babies is very rare, and less than 1% of all babies will be suffering from neonatal thrombocytopenia. So what is the goal in ITP? Because it's here the platelet count is very less. It can be less than 50,000. So what will you do? Again, serial monitoring of the platelets, and these spontaneous bleeding will only occur when the platelet count falls less than 30,000. So it was always aimed to keep the platelet count at more than 30 to 50,000. The treatment is always corticosteroids. You will do splenectomy only as a second line of management. The second line of management apart from splenectomy would be IV IgG or anti-D and some of these newer drugs. Like I said, corticosteroids is the first line of treatment. Now, when will you give this corticosteroids? You will continuously monitor the platelet count, and nearing delivery or when the patient gets into labor, just a few days before that, that is the time when if the platelet count is less than 30,000, that is the time you try to improve the platelet count. Your idea should be to make the platelet count roughly around 80,000 during delivery. So if she has a low platelet count, you try to in the third trimester, late third trimester during nearing delivery. That is the time when you will start giving her corticosteroids. And the doses, you give her IV corticosteroids, or you can give her oral if there is enough time. And you see that the target level of 80,000 is reached. And once you reach, then you can taper and maintain the dose. Now, whenever you put a person on steroids, it's important that there are certain side effects and you must monitor these side effects. She can develop GDM, she can develop hypertension, she can develop osteoporosis, or there could be abnormal weight gain. Sometimes, very rarely, she can go in for psychosis. Like I said, the second line of management would be splenectomy. If a person, in spite of giving corticosteroids, but platelets count does not improve, then you could do splenectomy. Splenectomy is only normally indicated in the second trimester and not in the first trimester. Whenever you do a splenectomy for these patients, you must remember that you vaccinate these patients, especially with pneumococcus vaccine. That is important. In refractory cases, you've done a splenectomy, you've given a steroids, she doesn't improve, then only you think of the other drugs like azathioprine, cyclosporine, etc. can be given. So whenever you see a person with thrombocytopenia, be it gestational hypertension or be it because of ITP, what will you do? Serial monitoring of the platelet count is important. You avoid NSAIDs at all costs. You avoid any trauma to the patients. Tell them, be very careful. Avoid all IM injections and try to keep the platelet count more than 30,000. In delivery, what do? You avoid scalp electrodes, vacuum or forceps. You must check the cord blood platelet. And during delivery, the platelet count should be 50,000 if you're aiming for a vaginal delivery. It should be more than 80,000 if you're planning for a cesarean section. So you should try to aim at that platelet count. As far as the baby is concerned, because if you have a baby born because of ITP's mother, you must avoid IM injection in the baby. You must monitor the baby's platelet count also, because around 1 to 5% of all babies can have a very low platelet count. So it's important that you monitor these babies. The other things that we come across is HIV-associated thrombocytopenia. Here, thrombocytopenia is more common, not only because of the disease, because of the drugs, and also because it could be concomitant viral hepatitis also. Then HCV, whenever a person has HCV, around 10 to 30% of all patients will also have ITP also. This is very important hit. This is heparin-induced thrombocytopenia. Just a few words about that. You identify hit only within the first 3 weeks of starting. So whenever you start the person on heparin, it's important that you see the platelet count. Here you are only concerned, it's more associated with thrombosis rather than bleeding. So there is no point to giving these patients heparin. Platelet transfusion should be avoided in these patients. The risk of thrombosis is very high. So you must give them some other anticoagulants. So whenever you put the person in heparin, after 3 weeks, you check the platelets and see whether the platelets is normal or is it low. If it's low, then you stop the heparin and switch over to some other type of anticoagulants. So how are we going to manage a patient with thrombocytopenia in the last trimester? A scheduled delivery is better. What do you mean by scheduled delivery? You fix a date. Don't allow her to get into spontaneous labor, because you do not know when she comes what the platelet count will be like. So around 36, 38 weeks, if she's crossed, then you fix a date and ask her to come for the delivery. What is the mode of delivery? You try to give her a vaginal delivery. There is no indication for a cesarean section except for obstetric indications. What will be the ideal count? Like I said, 50,000 for normal delivery and 80,000 for a cesarean section. Supposing you require multiple transfusions, like a platelet count is say around only 20,000. When you want to require multiple transfusions, because every bag of platelets will only improve the platelet count by 5,000. So if you want to improve it by another 30 or 40,000, in such cases, you give what is known as a single donor platelet. If you're giving a 10 or 20 units of platelets, you give everything by a single donor platelets. So when the platelet count is very low, that would be very ideal. So you just give it before delivery. And just to conclude, so you must know the common causes. Gestation thrombocytopenia is very common. The next commonest is because of preeclampsia and all its complications. The third one is very important, is ITP. So only serial platelet count monitoring is very important during pregnancy. If it's ITP, then you put them on steroids if necessary. During delivery, 80,000 for cesarean section, 50,000 for normal delivery. And in ITP, you see that you avoid certain things during labor, especially scalp electrodes, instrumental delivery should be avoided. And you have a check on the baby to see what is the baby's platelet count. Okay, with this, I really thank all of you for a very patient hearing, especially on a Monday evening. And I seek your support. I stand for medical disorders in pregnancy. And thank you, Kanchan Madam, for having given me this opportunity and having included me also, and all the very, very best. I wish I wish to ask everybody for your support for both of us. Thank you so much.
Thank you so much. This was a wonderful talk, madam. You have increased our intelligence, and all the best to you also, to me also, to you also, for the
all the very best, Dr. Kanchan, for all the efforts taken. Yep.
Thank you so much, madam.
Like madam said, Dr. Charimla, you don't look at the results. Do your best. That should be what is happening. So let's not see what's going to await us. but let us do our best. That is what
Our
we have
best.
to do.
Yes, yes, madam. Thank you. Thank you.
Thank you so much.
Thank you, madam.
Thank you, ma'am. Thank all the chairpersons, ma'am. Nice seeing you, ma'am. Shantirani, ma'am.
Shantirani is doing wonderful job.
Madam connection unstable. Chitra madam connection is unstable.
Yeah, mine.
Yeah.
Mine is it?
Yeah, madam. Now you are audible.
Okay.
So excellent talk, madam.
Thank
really,
you.
we are having plenty of thrombocytopenia. Every day we'll be
Very
struggling.
common, ma'am, nowadays.
Now we start using single donor platelet. SDB we are getting.
Because when the count goes low, no, that's better rather than giving many units.
During delivery, we used to get SDB. Madam, I think madam can take over the sessions hereafter. The panel moderator. Kanchan ma? Over to you, madam. Chitra madam, all the best, madam.
Share the CV of the moderators.
Yes, ma'am.
Good evening, Chitra. All the best for you.
Thank you, madam. Dr. Chand.
Thank you. Yeah.
Dr. Kanchan Sharma here.
Madam, Chandra, madam, had one doubt. Can small society secretaries vote? Kanchan, ma'am?
Yes, secretary, small society secretary will.
No, small societies can even secretaries can they vote is what madam wanted to know.
Because they say in other society, both the president and secretary, they will vote if the small
President
society.
And secretary can vote, isn't it? For all secretaries, is it only the A or B or everybody? Any society, president and secretaries can vote.
For A and B society, president and secretary both, and for the smaller society, only secretary will vote.
Only the secretary can vote. Smaller secretary.
So 50 members, no? Our society has got 50 members. So our secretary only has the right to vote.
Yes, ma'am.
Yeah.
Yes.
Thank you.
Just show the CV of Dr. Shanti Devi Sambat. She is a vice president of Madurai OBGY Society, and she's a great personality. She is moderating the today's panel. She was a former professor, Department of Obstetrics and Gynae Society, Government of Madurai Medical College, Madurai, vice president of Madurai OBGY Society, undergraduate and postgraduate teacher in Madurai Medical College and Theni Medical College for 18 years, organized many live workshops and presented many papers, special interest in infertility, endoscopy and ultrasound. Welcome, madam here. Welcome. I don't see her. Yes, madam.
Thank you, madam. Thank you, madam. I am here.
For the second moderator, Dr. Umail. Dr. Umail, you are welcome here. You are the secretary of Kanchipuram OBGY Society, and I am seeing you, and even on the WhatsApp, you are very active and very enthusiastic. I appreciate your involvement, madam. You are graduated MBBS from Chengalpattu Medical College in year 1988, gold medalist, Obstetrics and Gynae Society, managing director of Shri Kumaran A Specialty Hospital, and you are a founder secretary of Kanchipuram Obstetrics and Gynae Society, president of Indian Medical Association, Tambaram, and member of Practical Obstetric Committee of FOXI, special interest in laparoscopic pelvic surgery and reproductive medicine. Welcome, madam, here as a moderator. Now stage is yours. You can introduce your panelists and start the session, madam.
Can you? Yeah. Good evening, everybody. Now to the most important session of the day, obstetric emergencies, which most of us do keep.
In brief, we can introduce the panelists. Who are they and who are available at present?
Yeah. Can I have the
Dr.
panelists?
Shanti Rani is there.
Dr. Shanti Rani
is there.
Yeah. The panelists are Dr. Shanti Rani. We all know her. She's been very busy all this time, attending so many webinars and conducting so many webinars. Professor and HOD of Medical College Theni. And she's also the president of Obstetric Society of Theni, South Zone Coordinator for the Medical Disorders of Pregnancy Committee FOXI, and she's been awarded the Best Doctor Award by the IME. And also she has been given the Best Service Provider Award for PPI-UCD and lab sterilization. Her special interests are high-risk obstetrics.
Welcome, madam.
Dr. J. Amala Devi, she is the president of Dindigal Obstetric and Gynec Society. Welcome, madam. She is a senior consultant from Annai Perinbam Hospital, Dindigal. And she is retired in service, but she still looks so young. And retired as JD and project officer, Chennai. And founder secretary of Dindigal Obstetric and Gynec Society.
Welcome.
And the president for the past 10 years. And she's a member of so many distinguishing clubs in and around Dindigal, and has performed more than 50,000 of lab sterilization.
Welcome.
More than 200 adolescent health programs in schools and colleges. And she's been awarded the Women Achiever Award in 2020. And she's been awarded the 2022 Lifetime Achievement Award by the Thai Food Foundation. Welcome, madam. Dr. Saroja Velichami, the Secretary of the Dindigal Society. Welcome, madam, for the panel.
Welcome, madam.
Consultant at Karthik Nursing Home and has been involved in the rural service for the past 6 years. And she is working in the Dindigal Headquarters Hospital for the past 15 years. And she is the current Secretary of Dindigal Society of Obstetrics and Gynecology. Welcome, madam. Radha Madhavi, madam, from Tiruvannamalai. Everybody knows her. Welcome, madam. She is the founder president of Tiruvannamalai Obstetrics and Gynec Society, director of Rajam Multi-Speciality Hospital and Rajam Institute of Paramedical Sciences. She is also the joint secretary and EC member of the TNFOG. And she's also the member of FOXY, ISAR and IMS. Practicing gynecologist from 1994 onwards. Has conducted annual conferences like GestaCon in 17, 18 and 22 at Tiruvannamalai Medical College. Great, madam. Welcome. Next. Dr. Chandra Pondusamy, madam. She's an AC member of TNFOG. And she's basically from a Stanley Medical College, both are UG and PG. Has been awarded plenty of gold medals for her proficiency in anatomy, medicine, pediatrics, obs and gynecs. And has been associated with FOXY for the past 38 years. Life member of IMA, ISAR, PCOS and IAGE. Was the vice president of Namakkal IME. Founder secretary of Namakkal Women's Doctors Association. Founder president of Namakkal Obstetric and Gynec Society. Delivered the first IVF and first ICSI baby of Namakkal district. Was a faculty and chairperson in many conferences and awarded the Best Doctor Award by NIMA. Welcome, madam.
Welcome.
Dr. Vanita, Secretary Teni Obigain Society. Dr. Geeta from Gosha. She is the head of the Department of ONG from Gosha Hospital and presented papers in many national conferences. Recipient of A.L. Mudaliar Fellowship Award. Past Honorary Secretary of OXY, member of ISAR, IAGE, ASRM and SOFC. Welcome.
Good evening, ma'am.
Ittiga Devi. She is a consultant obstetrician and gynecologist from Babos Maternity, West Tamram.
Welcome all the panelists.
Yes, welcome, dear panelists. Shanta madam, you start with the screen.
Madam, 7 o'clock அவங்களுக்கு ஏதோ 7 o'clock ஆக்சுவலா உங்களுக்கு ஒரு ப்ரோக்ராம் இருக்கு போல மேடம். நீங்க 2 பேரும் அவங்க கான்பூர் மக்கள். நீங்க ஆளுக்கு ஒரு கேஸ் முதல்ல ஃபர்ஸ்ட் டர்ன்ஸ்ல போட்டுங்க, அப்புறமா செகண்ட் கேஸ் அதுக்கப்புறம்.
யாருக்கு மீட்டிங் இருக்கு? சாந்தி ராணி.
கான்பூர்.
Okay. So I thought I have the 2 cases for prevention as well as management. So if it is continuous, it will be easy, I take only 10 to 15
Okay, madam. Now just I'm informing you, take your own time. சொன்னத மட்டும் இந்த மெசேஜ் ஐ ஹவ் கன்வேட். Take your own time, madam. No issues.
Okay. Because we are running out of time, I will quickly finish. Okay. I thank the organizers for giving me this wonderful opportunity. to attend this webinar. So there are so many nice topics. So we quickly go directly to the panel. So my topic is postpartum hemorrhage. So now still we have some of the maternal death due to postpartum hemorrhage with a lot of preventive aspects and management. Still we have maternal morbidity as well as mortality. So 25% of maternal death is due to PPH, 2 to 4% following vaginal delivery, and 6% following LSES. Among this, atonic PPH constitute about around 70%, traumatic around 20%, and placental is 10%. So why we have still we have we lose some of the women due to PPH. So we all know all pregnancies are at risk. Risk for developing PPH, and no one can predict postpartum hemorrhage. However, that is the expertise in managing obstetric cases. So no one can predict PPH, and it occurs without any warning sign. We all know the delay. The common delay is recognizing and seeking help, and also to get the facility where treatment is going to be taken. And there is a delay in receiving early and appropriate treatment. So there's very many evidences say it is more dangerous is delay in diagnosis. So the delay in diagnosis is mainly due to the underestimation of blood loss. So always it is said that is overestimate blood loss is better than a underestimation. And so we have some modalities how to manage, how to overcome all these. So first, so we have so many definitions for postpartum hemorrhage. What is PPH? So we have so many. Dr. Shanti Rani, can you clinical definition for PPH? Dr. Shanti Rani,
theoretically, it's only 500 ml in a vaginal delivery and 1000 ml. But always we teach our postgraduates that any amount of blood loss that cause the hemodynamical instability in a patient, that should be considered as PPH. Because some anemic patient or with the low body weight patient cannot withstand even the normal amount of 500. So whatever the blood loss that causes the derangement, hemodynamical derangement, then we should consider it as a PPH.
Yes. So that is maybe a subjective variation. The amount of blood loss cannot be measured correctly. So this clinical definition is more relevant. Next, the first case scenario is she is a 25-year-old primate, term pregnancy, is without any high risk factors. She was admitted with the labor pains in a PHC. She is in active labor. So what are the? She is in low risk. Is it necessary to give Amstel or prevention is necessary? Amala Devi, madam.
In all cases, you can't predict which case, even though you tell that there are predisposing factors in some of the patients. In some of the patients, there may not be any predictive factors. So yes, always you better each and every case should be treated as she is going for a PPH, so that you can be more cautious and treat her, and the active management of third stage of labor can be followed to minimize
yes,
the bleeding.
Yes, madam. So all
it has not been given about anemia. Any other conditions is not mentioned. It is just mentioned as a 25 years old primate. So better you cost the staff nurse on the team or the obstetrician who is attending the delivery. She may go for a PPH. If she goes for a PPH, she is ready to manage the patient.
Okay, yes, madam. So we have to give Amstel, that is the prevention, that is all the steps of prevention. Amstel has to be given for all patients because we cannot predict. PPH, as madam said.
Every case of delivery, it should be followed. Every case of delivery, whether it is a high-risk case or...
Madam, what are the components? Madam, what are the components of Amstel? Can you enumerate the... everybody knows?
Amstel has a component. Say, ma'am? Amstel has oxytocin, control contraction, and uterine massage.
Okay. Suppose all the what is uterotonics we
generally use oxytocin. We use generally, ma'am. It is 10 units IM immediately after delivery. we have to store it, but it is easily available and it is economical. Recently, we have carbitocin also available, but cost-wise, it is very difficult. We use oxytocin only.
Okay, yes. Suppose
And if oxytocin is not available, methergine we can use 0.2 to 0.4 milligrams if the patient has PPH.
No contraindication. No contraindication. There is no contraindication.
There is no contraindication like heart disease.
The cardiac disease and all contraindicated.
And then we can use parectal misoprostol also, 800 micrograms, and injection prostadine if patient has no bronchial asthma. The maximum dose of methergine is 5 and for prostadine.
No, that is for treatment, madam. So it is, now we are talking about the prevention. So prevention, any one of the, yes.
We prefer carbitocin over oxytocin.
If one drug means oxytocin only, madam. If one drug means oxytocin is best, recommended.
Okay, Dr. Chandra Ponnusamy, madam, Dr. Chandra Ponnusamy. If everything is available, that is,
yeah.
Madam, everything is available, all the oxytocins are available, then which you prefer?
I prefer oxytocin, 10 units. Prophylactically, start already, she'll be in the drip and we add oxytocin in the drip. Slow IV. And as
Vanita.
Good evening, madam.
Vanita, what is the advantage of carbitocin?
Madam, carbitocin is can be stored outside, madam. It is heat stable, and biological effectiveness is more when compared to oxytocin, ma'am. And the longer half-life also. But the efficacy is similar.
So it is but it is used only for prevention. So when you use for prevention, that no need for additional oxytocin. That's advantage, and it is heat stable. So it is and also readily available as 100 micrograms vial. And so another thing is prostadine is should not be used for, as per WHO, should not be used for prophylaxis. It is the drug, it is a very important drug for treatment of postpartum hemorrhage. And another thing is we have to use any one
tranexamic acid. Madam, we can use tranexamic acid.
That is for treatment.
Not euprotonic.
That can be used as during
tranexamic acid is not euprotonic.
No, that can be used during LSCS only, no? LSCS to minimize the bleeding, tranexamic acid can be used, but not as a routine in third stage management.
Prophylactically, tranexamic acid is not recommended, madam. Not recommended. Prophylactically.
In foreign countries, within 3 hours.
They come to the treatment.
3 hours.
So from
Yes,
the
it is
first
not
case,
euprotonic.
yes, madam. It is hemostatic. Okay, the message from the first case is should be given for all birth irrespective of the risk factors for the prevention of PPH. So this causes uterine contraction. So even if the patient develops postpartum hemorrhage, it will take care of that. That is the advantage. And it should be effective uterine tonic should be given immediately after delivery. And whenever that is not available, then you have to consider the other things. If the contraindications are caused, we can use other uterotonics. And the ideal is 10 units oxytocin intramuscular immediately after birth. And it can be continued as 10 to 20 units in infusion for the sustained contraction. So now I just management part also, within 10 minutes we can finish this. So the next case is a 28-year-old, the reproductive para-1 live one. It's a para-1 live one. She delivered just now by vacuum in a tertiary care center at 4 p.m. It was uneventful. At 5 p.m., she gives a history of giddiness and she looks restless and pain. Her blood pressure is 100/60. Pulse is 112 per minute. She has vaginal bleeding and uterus is flabby. So this, everybody knows it's a case of postpartum hemorrhage.
Atonic PPH.
Okay.
Shall I answer?
Could it be preventable, Saroja madam?
Yes,
Yes,
bleeding inside.
Could it be preventable?
Yes.
Definitely,
Yes.
Can be preventable.
If we have followed 8 years, it is preventable, absolutely.
No. It's not audible.
Not audible.
Yes, now audible. Now audible. So it is preventable.
It is preventable. It is preventable.
So what is the problem with this case? Why it is not diagnosed early?
You monitored only after 1 hour.
Yes. So
delay in diagnosis.
So what could be done? What could be done to avoid the postpartum hemorrhage? Or now the patient is having some pulse rate is high, no? So she is having some hemostatic instability. Tachycardia is there. So what would have been done?
Vitals monitoring every 15 minutes. The
golden hour should be.
We should have
anticipation. She is second gravida, vacuum delivery.
So more
prolonged labor.
Prolonged labor.
Monitored. She would have monitored properly.
So what is the important sign of postpartum hemorrhage?
So she had become restless. She had become pale.
Tachycardia is the first warning.
Tachycardia is there. Bleeding is there. Bleeding is there.
Yes.
Above
So
all, uterus is flabby. So she must be
the
having
postpartum
period.
hemorrhage diagnosis is only visualization of blood loss. All the other findings
also the patient.
That is, madam, that is they were going for a hemostatic instability or hemorrhagic shock. So that is the stage wise. But only whenever you see the bleeding, it is diagnosed as postpartum hemorrhage. We have to start immediately. We have to start the management. So this is to diagnose early. We have to monitor the patient as you said. We have to monitor the vitals every 15 minutes for first 2 hours. That is the golden hour. And also you have to palpate the uterus, see for bleeding. So this is very important to diagnose early.
Shall I add, madam?
Yes.
Usually immediately after delivery, after the delivery of the placenta, we palpate and see whether the uterus is contracted. And especially in instrument delivery, in addition to all this, we have to inspect the cervix to rule out any trauma to the cervix. Any instrument delivery, either it is vacuum or because sometimes vacuum is we introduced during without even before full dilatation. So
yes, madam.
So
exactly.
Inspection of the cervix is a must. All these should have been done. Then already 1 hour has been wasted. So all these things, active management is very, very essential. So that to avoid PPH, we can avoid PPH in this case. Once it has come, then we rule out all these things. And as you said, we have to do all these things.
Yes, madam. Now the BP is 160. Will you wait or will you start treatments for it?
We have to start.
Treatment.
Then what is shock index?
Shock index is heart rate by systolic pressure.
Divided by systolic blood pressure.
The normal is 0.7 to 0.9. It has 4
if it
stages.
Goes beyond 1. If it goes beyond 1, it is more dangerous.
Yes. So the shock index is heart rate divided by systolic pressure. So the stage 1 postpartum hemorrhage, it is normal. The shock index should be normal. Stage 2 is 0.9 to 1.6. And if stage 4 means it is to collapse. Anywhere the reading, the value is more than 1.7, it is poor outcome, very severe. And so how to go about this case, Dr. Madhavi?
Immediate resuscitation is necessary. Already she will be on IV line. For any delivery case, we are keeping the IV line, Whitmore line. Start trigger like that immediately and saline immediately. Then we can order for the blood.
We should have
Call
2
for
IV
help.
lines, ma'am.
Call for help.
This is the first thing we should do.
Yes.
Call for help.
That is completely, it is a mnemonics, no? Call for help, airway, and M for uterine massage, O for oxygen. So we have to go by that.
Yes.
So one line we have to put IV fluids, and another line we have to put oxytocin infusion.
30 trays.
So 30 trays the bladder.
You cannot manage alone. That is most important. Is call for help. Don't try to manage single-handed. So you call for help, and by phone or some labor ward, especially in medical colleges, they have a calling bell or buzzer like that. So immediately the team should arrive. So minimum 4 persons should be. Minimum 4 persons
should be given call over. Anesthesia should be given call over.
Okay. And
actually, in medical college, we have a code, madam, red code, so that whenever there is a PPH, we'll make a call to everyone that is concerned. That should be followed in private practice also. That will be easier.
So, Madam, Saroja, madam, what can be done in private practice? Suppose we get like this in a private practice, what can be done?
Practice, every staff will be available by the side of me. At the same time, we give follow-over to my anesthetist. My anesthetist will come and immediately we should pack it. We should pack it and shift the patient to the theatre.
Okay.
But in my labor setup, I have got boils apparatus and a good light. So I will manage even in my labor ward itself. With the anesthetist help, I will manage.
Okay, so the team and proper communication is very important. Now, will you inform the patient and relatives and what is the unique consent? How will you inform the patient? Who will inform? So one of the team, they have to inform the patient and what is happening and what we are going to do. That has to be explained, and everything is one of the team member has to monitor everything in the case sheet also.
Communication and documentation.
Now the recently, what is anything about anybody about the bundle management? Dr. Kritika, are you there?
Yes, she's there. Kritika madam is there.
Or anybody?
Madam, bundle management is the first bundle. It has uterine massage, IV fluids, uterotonics, tranexamic acid, ma'am. If it fails, we should go for the second bundle approach, which consists of bimanual compression, aortic compression, balloon tamponade, NAST, ma'am. Initially, we have to do the first bundle has these components along with that supportive measures as we do like IV fluids, blood.
Fluids, uterotonics. Uterotonics is the major component in the first bundle.
So the first bundle, so there are 4 components. Can you, Madam Madhavi, madam is there? Massage.
வாங்க எவ்வளவு கட்டணும் 9,000 கொடுத்துருப்பா.
Anybody?
Uterine massage in a cephalocaudal direction we have to give.
The clockwise direction. It's a clockwise direction. You never lose the fundus in the abdomen. You should catch hold of the uterus in between your hands. Then you start massaging from in a clockwise direction. Continuous massage.
So what is the role of IV fluids? So we have to start IV fluids immediately. Everybody accepted. So what is the role? How to give? How is the
100 to be given in 15 minutes.
15 minutes? How much she is?
Madam, 2 liters we have.
How much?
More than 1.5 liters will cause a hemodilution. One day Vanita told me, no, IV fluids, I am rushing. I told you, transfuse blood first. It's only till the arrival of blood you can manage with the IV fluids, madam. Over excess of IVF will cause a hemodilution. So dilution coagulopathy will be there. So we should not be very drastic in managing the case with IV fluids. You can give
Yeah.
Our aim is okay.
What we do in private practice, no?
We have to give IV fluids, madam, till the blood comes or till she's not having any evidence of hypoperfusion. Only you can give up to 1.5 liters, not more than that when there is an ongoing loss.
Yes.
That's what I feel. Moderator has to tell. Madam Shantadevi, madam, you tell.
Excuse me. Usually, what we do, once placenta has come out, uterus should contract. If it is not contracting, you see for whether uterine cavity is completely empty. Even if the placenta has come, sometimes membranes will be adherent. So if the os is not closed, that means then there is something inside. So in our private practice, what we, this fourth stage, we care them. We'll be along with the patient, and then if it is the uterus is not contracted or something is inside, and we see for the any bits of membranes, then we see for the cervix, speculum. We'll be having sponge holding forceps in the labor room. Immediately we see. Then immediately we'll assess why she is going in for PPH. So 1 hour after the delivery, fourth stage is very, very important. And if we suspect anything, then what all things we use, we start the IV fluids and uterotonics we give, and we look for massage. If it is bladder is full, then uterus will not contract at all. So as Dr. Geeta said, we get it right, and usually this will help. Then again, if she is going in for PPH, then the routine management, because we don't have any help, and immediately we cannot get any help. So we are the staff, we are the anesthetists, and we are the obstetricians, everything. So this way we keep on doing it.
Don't be extra careful.
Even for us, madam, anesthetists will not come immediately. We have to manage, and we won't call them also, we will manage.
Yes, that's true. Okay.
Madam, connection has gone, I think.
Yes. Hello.
I think connection has been lost, madam's connection.
Umayal, madam, you can start now.
Yeah, shall I?
Yes, yes.
Very nicely discussing the case of the PPH, how much amount, all the discussions were very intelligent. So, Dr.
Shanta Devi came back again.
Am I audible? I lost connection.
Yes, madam, audible.
Yes. So the first, so the uterotonics are, I think we have discussed. So all the most important thing, whatever available, we can give more than one oxytocin, depending upon the factors like contraindications or availability, cost. So these all the prostaglandin, methergin, and can be suppose vasopressin not used for prevention, you can use for treatment. So what is the role of tranexamic acid? Dr. Kritika is there?
Yes, please.
It's an antifibrinolytic. So it can be given as 1 gram in
3 hours of delivery we have to give, ma'am.
No, it can be given during a cesarean section, no? Not during a normal delivery.
15 minutes
It
before.
can be given during a cesarean section.
Yes, madam. That is, it is WHO recommended for treatment of postpartum as early as possible within 1 hour. That is more than after 3 hours, it is not very useful. As Amala madam said, you can be used for cesarean section for prevention. Some of the obstetricians are using, but recommendation says
sometimes they recommend it. Anesthetists, they wanted to give us if there is the bleeding along with the syntocinon, and sometimes if we give prostaglandin, and then carbitocin is nowadays we start doing it, but not much of the obstetricians
so we have
started, I think, because of the cost, and it is not available in government hospitals, no, because of the cost. Private practitioners are using it.
But we can get the government hospitals also. They can get. I think Santirani must be.
We do have tranexamic acid in.
And so now we have completed the first bundle. That is all 4 components has to be given either simultaneously or be given simultaneously. But the order we can change. So supportive measure also very important. So that is as soon as you conduct the delivery, if you diagnose PPH, especially in instrumental delivery, even without PPH, you have to examine the vagina and the cervix. Okay. So what are the other supportive measures? So, already it is given emptying the bladder, emptying the uterus, and you have to monitor the vitals. So these are the supportive measures have to be done. So we can change the order also. So you supportive measures first, simultaneously some other person can do the other component of the bundle, first bundle. Okay, so now coming to the second bundle. So this is the first bundle, the acronym motive. Okay, suppose the first bundle, we have completed the first bundle. Most of the patient will do well with the first bundle. Suppose the country is bleeding, it is called refractory PPH. So the definition of refractory PPH is any. So whenever is unresponsive to initial treatment, so we have to go for the second bundle. Anybody tell about the second bundle components?
This massage.
Second bundle has bimanual compression, balloon tamponade,
aortic compression. It's anti-shock garment.
Vascular ligation.
So there are three components. Three components. Madam, Radha Madhavi madam, can you tell about the bimanual compression, how it is to be done? It's very important maneuver. You can save many patients from PPH during cesarean section as well as in delivery. Shanti Rani?
No, Radha Madhavi madam is not there, it seems. Bimanual compression, I always remember you only, madam. You used to do and you used to hold for more than 20 minutes. You used to compress the uterus in between your hand. You make your right hand as a small cube like this thing, and you post the anterior fornix, anterior lip of the cervix posteriorly. Then you hold the other hand over the fundus, and you compress in between your hands and keep it for more than 20 minutes. So that it slowly.
Till the uterus contracts enough. Meantime, we can go do other sticks and everything you have to give. So this is the way we have to do bimanual compression. Can be done in normal delivery as well as during cesarean section. And the other compressive, that is the second bundle components are compressive measures, which includes bimanual compression, aortic compression. So aortic compression, Geeta.
Aortic compression.
Aortic compression, pressure over the aorta, madam, between closed fist and vertebral column. It's a temporary first aid measure, ma'am.
They are not routinely doing, no?
We are not.
But it is.
First, we have to feel the femoral pulse, madam. Then we have to give the aortic compression. We will feel that femoral pulses will not be there if we give correctly. Am I right, ma'am?
Yes, you're
yes. Yes. So this will.
If the bleeding is severe, no, you should stand on the right side of the patient and place the left fist just above and to the left of the woman's umbilicus.
Directly over the umbilicus.
Abdominal aorta passes slightly to the left of the midline, no?
Yes, madam.
So you should be able to feel the aorta against your knuckles. Before, yeah.
But how many of us have
aortic compression?
Madam, how many of us really did this?
So it is difficult
Before
to
accepting the aortic compression, you should feel for the femoral. And then you should do it and see that it is absent. If the femoral is absent, that means you have done the aortic compression correctly, no?
Yes, madam. Exactly. So, exactly. So suppose if you are comfortable with the bimanual compression, you can do either any one of the compression muscles will do. So these are all the temporary measures only. So you have to, whenever we keeping ready for surgical management or shifting the patient, we can avoid excessive bleeding. You can do this maneuvers. So next one is the.
If you are not able to tackle the patient in your center, if you are not able to tackle the patient in your center, it is better you refer earlier. Earlier referral is best, because if you don't have the team to assist you, or if you have a doubt in resisting the patient, the anti-shock garment can be used and she can be shifted as early as possible. So that is the best thing we can do when there are only one obstetrician, or there is no other personnel, or your team is not good enough for you at that time. So better you refer the patient using the anti-shock garment you can just shift her if you got the anti-shock garment with you.
Yes, madam. So these are all the three components for second bundle. So the we can, as you said, we can shift the patient by using any one method. This is the second bundle, but we need not use all the three like first bundle. In the first bundle, we have to use all the four components. Here you can use either one or two. Combination of two is will do till we shift the patient to either to the theater or to other institution for the management. So now the balloon therapy. Vanita, any idea about balloon?
Ma'am, uterine balloon tamponade can be done by Foley's or gloves or condom tamponade can be done, ma'am. It can be done by Foley's single or 2-3 Foley's can also be introduced into the uterine cavity, and it is dilated to 70 to 100 ml, 70 to 80 ml, madam. Depending upon this thing. And if it is a condom,
so now
okay.
So there are some disadvantages of police catheter. So now it is devised by the Thomas Burke. That is the ESM UBT. That is anybody have seen this? Every second matters. That is uterine balloon tamponade kit. Am I audible?
Yes, ma'am.
Yes, ma'am. Okay, so this kit is soon available in, I think, in government hospitals also. The advantage is here the syringe, 60 ml syringe will well fit into the catheter. It is PVC, not a rubber catheter. It's a PVC. So it is rigid, and you can easily introduce. It has two rubber bands for the condom, and also it has a
and ordinary gloves can also be along with the condoms. You can use the gloves also.
Gloves, we can insert up to 150 ml also.
And
you need not wait
additionally, we can pack the
very
vagina so that the fluid will not leak.
Hi-fi.
But for that we have some other, like police catheter, the bulb we have. We have to inflate the bulb with 15 cc and the condom with 300 up to 300. Maximum 1,000. But once the bleeding stops, you can stop.
And it should not be removed within 24 hours.
Yes, ma'am. Minimum 12 hours. Minimum 12 hours. We have to.
Hours you can remove it.
And we should watch for hemodynamic stability, instability is there. We have to watch for pulse and blood pressure again.
How it acts, madam? How it prevents PPH? Uterine balloon therapy. How it prevents? How it prevents or how it stops?
Pushes all the fluid to the from the belly to the major organs. They say vital organs. That is the thing. It prevents the. It pushes the blood to all the vital organs.
Not only that, it directly compresses the
vascular bed.
Compression on the placental bed.
Renal arteries are compressed.
Vascular bed is compressed.
So these are the bundle. Some support measures for second class. Anti-shock garment. This is again the pressure. So now, with the lack of time. So this is the actual bundle component. So can you see the response? All component has to be used between massage, uterotonics, IV fluids, salicylate acid. Meantime, you have to arrange for blood, and the supportive measures are emptying that is a look for lacerations in vagina and cervix, and empty the bladder, empty the uterus. Which again, if there is a full bladder and the uterus is filled with clots or any placental tissues, cause more of atonic PPH. And if it is not responding, you go for a second refractory PPH response, the second bundle. Here we have to the compression measures and the uterine balloon tamponade and the anti-shock garments. The supportive measures here is the blood as well as ready to transport the patient to higher centers. So this is the bundle management approach. So it is, if it is done correctly, most of the patients can be saved. So till about 1% of PPH will not control with these measures, then what next?
conservative surgical procedures.
Surgical, okay. So now today I'm not going to discuss about the surgical. So suppose if you are doing cesarean section, in the cesarean section is what are other methods of controlling PPH is SR cannula. Yes. Anything else? Suppose you are doing cesarean section, the patient is electronic PPH.
In some patients are practicing this intermittent suction. No? They keep the suction tube inside the uterus, and then periodically the clots and the blood inside the uterus is sucked out, so that the uterus is kept compressed. So negative pressure is created inside the uterus, so that in most of the some of the practitioners are doing that also, and they have saved the patient also.
So some of them give intrauterine methogen, madam.
Intermittent suction, not continuous suction.
Yes.
It is intermittent suction, keeping the Foley's catheter inside, and with the suction apparatus, they are clearing the blood clots, and they are not allowing the uterus to become flabby. They are keeping the uterus contracted.
So for that, there are so many Panicus cannula and SR cannula. Many practitioners are using in government hospital. Peni also they are using Shantirani. So they are using but it's costly. That is why the ESM
all government hospitals having SR cannula started using it. It's more of a physiological process. Like it makes the uterus to contract rather than to make the uterus distant and compress the vessels. It makes the uterus to contract physiologically. So that is more appropriate, and it is recommended by the NHM people. So we are started using that SR cannula. Geeta will be telling that.
Yes, ma'am. We have 5 cannulas given in size. Vaginal separate cannulas and for cesarean separate cannulas we are using. And it is very good, ma'am. It's recommended by NHM.
Yes, ma'am. So these are all other methods. So whichever we are used to it, we have to use to stop the bleeding. And so blood transfusion, about one last thing to discuss, that is a blood transfusion. So which blood do you prefer? Geeta.
Component therapy is preferred nowadays rather than whole blood.
So for
immediate whole blood, why you are not?
Immediate blood transfusion, whole blood is initial starting whole blood, no?
Paxils,
rather than component therapy.
We don't know group. Immediately, if we have to give, we can give O negative.
And then you can go for the next.
But in recent years, it is said the whole blood is not used. Only the component, that is the Paxils and FOP.
Yes.
1:1 ratio.
The ratio is 1:1:1.
Yes.
Paxil, FOP, and platelet.
The reason is, madam, the whole blood, the temperature, at that temperature, many of the clotting platelets. Yes, madam. So we have to use component therapy. That is Paxils and 1:1 ratio. So this is mostly.
Hello. Shanta, madam, not audible, madam.
Antarevi, ma'am.
Not audible.
It's not audible, ma'am.
Madam, Umayal madam is having one case now. We'll start that. Umayal madam.
Okay, ma'am.
We are having only 15 minutes more, madam, so that we can finish it up. Madam, I think network is not good.
Shall I share my screen?
Yeah, please, madam.
Yes.
இது எடுத்தாதான் நான் என்னோட ஸ்கிரீனை ஷேர் பண்ண முடியும்.
Okay.
Have stopped.
Sarida?
No.
Madam.
Really, yeah.
No.
Share Ali. Shield people are there, no?
Ma'am, please click on share screen button, ma'am.
Yes, ma'am. This was a very wonderful session. I saw that everybody was bubbling with the knowledge and shared a very good knowledge about the PPH, starting from the atonic to see the trauma of the cervix. Then starting with the oxytocin, all the discussion went very right way in the using of the oxytocin, methergin, and carbitocin, what should be used, what not to be used, and the different bundles of the PPH, first, second, and the third bundle, and all the levels. Because of the shortage of time, I think we are not going for the surgical approach. We will have sometimes else session. Madam, Dr. Shantirani, do you want to continue or?
Umayal madam is trying to share her screen.
Yes,
Yes, screen is getting shared. No.
It is not getting shared, madam.
You can orally tell the case, Dr. Umayal.
Madam.
You can.
You want to talk about sepsis, madam?
Yeah.
Well, madam.
Yeah. I'm just trying to share.
Just click on share screen. One pop-up will be raised. Visible, ma'am.
In the meantime, I want to thank you for the opportunity given to me. And actually, we
Is
learned
it getting
from.
shared now?
No.
Oh, yeah.
Sharing ma'am. Now it's coming.
Yes.
Actually, only five of us only there. Geeta, myself,
Amala Devi madam.
Anita, Amala Devi madam, and Chandra ma'am. Only five of us.
Screen share, Aicha?
Yes, ma'am. Ma'am, could you please make it full screen?
Slideshow. You put it on slideshow. Yes. From the beginning.
So this is the first case.
No,
it's not in slideshow mode, ma'am. And from beginning. Click on from beginning.
Yes, first from
This
beginning.
one, ma'am. Left to the left.
Left.
Clicking slideshow to the left from beginning.
First column, yes.
Yes, ma'am. Super.
So this is the first case. This is a 29-year-old Mrs. X who has been referred on her 4th day of post-cesarean delivery with history of fever and increased pulse rate. And on examination, there is tenderness in her abdomen, diffused tenderness in her abdomen. And her basic investigations are hemoglobin 10 grams, and her WBC is slightly raised. Her electrolytes are normal, and her functions are normal. Basically, her LFT and RFT are normal. So, what are we supposed to do next?
Ultrasound.
Do basic blood investigation.
Yeah, basic blood initially as soon as she comes, it's showing normal except for the increased WBC. So an ultrasound is being done. Here the uterus and the ovaries are not separately imaged, and a collection with septations. Internal glucose are noted between the anterior abdominal wall and the uterus. Almost 310 cc of fluid is being collected, and the adjacent tissues surrounding the adjacent tissues. Echogenic one, the free echogenic fluid in the abdomen is seen. Bilateral pleural effusion and with the bilateral mild hypoechoic kidneys are seen. So what is your diagnosis and what is the plan of the management? Shanti madam.
Madam, first of all, we should monitor the patient for all the vitals. What is their temperature, what is the heart rate and pulse rate, and other than that, urine output, how much, whether their urine output is good or not. And you have to go for LFT, RFT, that I want for this patient. Then everything is normal. If her urine output is good, her LFT, RFT, everything is normal, and it's
yeah, basic investigation.
Then you consider if you can go for because you said it's an 8 cross something.
14 by 9 centimeter collection is 310 ml.
So you can put a needle and take the fluid, send it for culture. So you see whether it is a pus or it is a
blood clot.
Only fluid, no?
But
it is echogenic, madam, most probably.
Madam, rather than going for that, you can go for a, if you want a culture, you can go for a blood culture and high vaginal swab culture for this patient. This is an obvious case of some intraoperative collection. Either it has to be managed conservatively with a high level antibiotic, or if it fails, then you have to go for a surgical management. That's my opinion.
Yes.
That's you can ask for other opinion also, madam.
Yeah.
Patient is symptomatic, madam. She has fever and there is leukocytosis.
Tenderness. She told tenderness. Extreme
also.
Tenderness.
All over the abdomen.
So we can, I don't think we will
set
with antibiotics.
Fluids, no?
Yeah. So we have to open her up and see what's inside, because it's an obvious case of sepsis there. So the best thing is to let out the pus. Only then the patient starts to recover.
Yes.
So it's a diagnosis of post-operative sepsis with the peritonitis. And as you all said, the proper investigations was done. Blood sent for culture, ABG done, antibiotics high. What next?
Laparotomy.
Laparotomy.
Yeah. So patient was put on NPO and posted for laparotomy. Just prior to the surgery, patient is actually becoming dyspneic. The prognosis was explained and taken up for the surgery. So what are you actually planning on the table?
Conservative management is our plan, but may end up with the hysterectomy. That consent also we should get.
Yeah. So
consent for hysterectomy also.
Before we go, proper counseling, because the patient is not ours. So we really don't know what happened inside. So better to sit and have a detailed counseling session, get the signatures for everything, and then take her up for the surgery. And so on the table, purulent free fluid and encysted collection anterior to the uterus, which was communicating with the uterine activity, uterine cavity. So what do you do next? Madam Chandra, Madam Solanga, Madam.
Yeah, since it's communication with uterine cavity, usually
should be a pure
for hysterectomy.
Hysterectomy. She is para 2.
Gravita 2, para 1.
But the sepsis will be there only, no? If you leave it, and she'll develop a sinus also.
Yes.
If you leave the focus, then anyway she is para 2. So before
the uterus is actually very friable.
Yeah. It's necrosed almost.
Yeah, almost necrosed.
Then better to go for hysterectomy.
Hysterectomy.
Yes, the patient can live without a uterus than to die with the uterus.
Yes, exactly. So we did a hysterectomy. The tissues were very friable and the abdomen was closed with a drain. And she had a very stormy post-operative period and she recovered ultimately. As Shanti Madam told, she went home alive without a uterus.
Yes.
So the basic thing is like the persistent hypotension was there, and resuscitation, she needed vasopressors to keep her vitals online, and she went in for acidosis. And so this is just an graph to tell us like how to assess the septic sequential organ failure assessment score. So here we have the respiration rate, the coagulation profile, the LFTs and the RFTs, and the cardiovascular system, the CNS score, and the output, urinary output. So we have the score between 1 and 4. and 10 is basically a normal thing. And once, actually, this patient, when she came, her respiration rate was 40. So she was already dyspneic with a high fever and with a tachycardia. So the period was stormy, but she recovered slowly. So
what could be the reason for her infection? Either she was an MRO or premature rupture of membrane handled outside when it came to
could have been blood collection during cesarean, blood collection unnoticed. That could be the most common cause.
Usually hematoma missed during a cesarean section, that also will end up like that.
Yes, it could be the thing.
Or the extensive adhesions which was tried to release previous intraoperative intraoperative sequence. This is due to
she survived because she didn't go for septicemic shock.
Yeah.
She didn't go for a septicemic shock. No, that's why she recovered, I think.
Yeah, shall I tell you one thing, madam? Since she is not our case, the patient's attender might ask us that whether it is due to the previous obstetrician's fault or something. So it's better not to reveal anything. Infection can happen
anywhere. Yeah.
Yes.
Any case
So
can
it's
go for
better
this.
not to let down our previous position. That is
That's true.
very, very important.
Madam, last week we had a similar case exactly like this, primary cesarean done. She came on 26th POD with a complaint of loose stools. The next day she had a fever. We did scan, the same collection was given. Then immediately we did laparotomy. We got hysterectomy consent too. But we saw more of abscess, purulent thing. Uterus is firmly contracted, normal uterus. We don't know where was the abscess, but there was a large, more abscess. We drained and kept the drain, given IV antibiotic, higher antibiotic, and she is fine now, ma'am. Third POD now.
We also had a lot of experience like that.
So in
and we are also seeing most of the cases posted in maternal death group, patient dying of septicemia. Geeta, you will be seeing, no?
Yes, madam. But I also asked the surgeon to have a look any particular abscess perforation, and we both ensured that nothing is there, and we conserved the uterus.
Madam case is very specific. She told there is only pus and it's communicating with the uterine cavity. So the source of infection is only the uterus. The source of infection should be always removed in any septicemia.
So hysterectomy was done and the patient recovered well.
Your case could be, Dr. Geeta, it could have been secondary hemorrhage due to infection, slow leakage, because the 26th day, no?
Yes,
so got collected in the POD. That's what the loose stools and all. Could have been that, yeah.
So the investigations should also be done and followed up and make sure that the patient recovers. So the blood culture is very important, and also a urinary culture with wound sepsis. You can have a swab of the wound also, so that it will be useful for us to treat her. And these are the other tests, if necessary, can be done. But basically it is a clinical judgment, and ultrasound itself is mostly sufficient for such cases. And so we gave her a broad spectrum antibiotics, fluids, vasopressors, and we kept her in ventilator for a day. And she recovered with nutrition supplement. So sepsis is a very important complication which we often face. So we need to think of the fabulous, the fluid, the antibiotics, the blood culture, the urine output, the lactate levels, the O2 saturation. And within the first 60 minutes, if we are able to assess all this and take care of the patient, probably we are going in the right direction. So the sepsis 6 is what we need to focus on in the first 60 minutes of the arrival of the patient. So antibiotics is must, at least for the initial, till we get the cultures. For the first 3 days, the antibiotic should be of the high order. We can go with the piperacillin, tazobactam, aminoglycoside, and then later on we can follow it up with the appropriate antibiotics. And management of the other systems as well. So this is the case of the sepsis. So basically we have to identify, do the investigations and take remedial measures. and make sure that the primary foci of the sepsis is identified and taken care of. And with good supportive management, the patient should recover. So as we told, since it was a cesarean section, uterus was the source of infection, and after the hysterectomy, she slowly recovered back and went home. She was there in the hospital for almost 20 days.
Congratulations.
Shall we do the next case, or we will?
We will finish fast, madam.
Yeah.
Okay. This is one very simple case. This is a 23-year-old primate with a postdated pregnancy. On admission, her antenatal period was not that case, but this case. So this is a 35-year-old primate gravida, the full-term pregnancy. She comes with pain since 4 hours and leaking PV for just 1 hour. She was a booked case, and her antenatal period was uneventful. So on examination at admission, she seemed to be okay. Her pulse rate was normal. Her BP was also found to be normal. Whereas everything, basically, she seemed to be normal when she entered the hospital. And after examining the patient, and the uterus was found to be full-term cephalic presentation with a regular heartbeat. Fetal heartbeat was found to be normal. There was a frank leak per vagina. Liquor was clear, and cervix was 1 centimeter dilated with 40 centimeters effaced. Per vaginal examination shows that this patient is at -1. And so with all these, the recent investigations, the hemoglobin was found to be 12.5 grams with almost normal findings. All the investigations done just recently was found to be very normal. And the CTG at admission was also normal. And just when we are transferring the patient from the casualty to the labor ward, she has 3 episodes of vomiting and had a tonic convulsions just while we were transferring. So we are, what could be the scenario here? Like, what do you suspect? A normal case without any pre-warning, any symptoms of previous problems. She suddenly has 3 episodes of vomiting and she starts convulsing. So anyone wants to take?
Any patient, if she has convulsions during antenatal period, it should be considered as eclampsia.
Okay, so we also thought like eclampsia. She was not responding to the oral commands, and she became apneic and cyanotic, and oxygen just by giving support. We called the anesthetist. The IV lines were secured, and she was shifted to NICU, and she regained consciousness within 5 to 10 minutes, and she was post-ictal, but her vitals became stable. She slowly became oriented to time, place, and person. And then subsequently, when we check the heart rate, there is a bradycardia, say 80 beats per minute. So now we have to plan the delivery. So how do you plan it? At this time, like what will be your management criteria?
Usually
you stabilize the patient after a convulsion. I more in go for abdominal rather than a vaginal delivery.
With the oxygen, oxygenate the patient.
Shift the patient. Yeah. So we are all.
Still, we are not definitive about the diagnosis. It could be it could be an MRI. We may need an MRI to know the diagnosis, or it could be an amniotic fluid embolism that also can occur. Then it could be a seizure disorder, what we would have missed history, or a partial atypical eclampsia where the blood pressure is normal but patient is throwing convulsions. So many things are there. But at this point, I think we can deliver and then we can go for other investigations.
So since the baby's heart rate is reducing, we are shifting her to the OT, and we are doing a cesarean section under general anesthesia. Baby delivered, and but it did not cry. So the baby was intubated and shifted to the NICU. Uterus was well contracted to start with, but just when we are closing while closing the uterus, we feel that there is a bleeding occurring from the surface of the uterus, rectus muscle, and subcutaneous tissue and all that. So immediately the anesthetist is informed, and he is giving injection tranexamic 1 gram IV. So the hemostasis is somewhat achieved, and we are closing the abdomen. And any cause of worry now? Like if
she has gone for DIVC.
Going for DIVC. Yes. Okay. So you're all suspecting DIVC. Yes, good. So that's what was actually happening to her on the table. So within half an hour, all these changes are happening. So investigations, we are immediately taking some blood and sending for investigations, and we are also trying to do the
profile.
We can give FFP cryoprecipitate if available.
CBC with platelets and
first we
cross matching.
Bleeding time, clotting time, bedside.
Yeah, the reports immediately which came was found to be very normal. You see the platelet is actually 1.53. The hemoglobin is also normal. So, but immediately after the immediate post-op period is hectic. The pulse rate is now she's having a tachycardia with a fall in BP. Now the Ryle's tube aspiration is blood stained. There is an hematuria and also the bleeding from the puncture site. So uterus is well contracted, but active bleeding is there. Whenever you press the uterus, there is a gush of blood. So now again, the subsequent investigation shows that the platelet is falling. The DAC profile also we have taken. The PT INR is slowly raised, and D-dimer is not useful, but anyway we did the investigation. And patient has continuous bleeding after the closure. So the provisional diagnosis is yeah. So most of us have encountered such cases. So what next? Yes.
Yeah,
okay. So one person was managing the uterine massage. Then a few people were running around to get the bloods. And in the theater itself, we never shifted the patient from the theater. We made sure that the blood was given. And so we gave 6 units of blood with FEP and cryoprecipitate and platelets. All this we gave. The patient was in the theater itself. We never shifted the patient till she started to recover. And then almost 3 hours, slowly the patient started to improve, and patient was shifted to ICU. So now, madam, your comment, Amala madam.
She recovered completely, no?
Yes, madam. She went home.
Now she is in ICU or recovered.
Recovered.
Neurological deficit.
Baby also was fine. Baby also went home very nicely. So with next day,
quick progression to DAC, no, ma'am.
Yeah. So actually, what I was thinking was this patient actually had an amniotic fluid embolism at the casualty, and because of that only she's having the convulsion, and that is resulting in the DAC. So within half an hour, amniotic fluid embolism followed by DAC. So that is what I thought.
But the BP is 170, 100
here in developing.
Yeah, it is developing.
So developing countries, this eclampsia is the most cause for this DAC, you know, in our countries and all.
But initially she was not having any features suggestive of.
So even though for us, we have to expect these complications in all cases of toxemia, pregnancy. Better you should be very careful looking at this thing. When it will come, we don't know. No, that is, you can't predict for which patient will be going for DAC.
Every
so
case we have
you
to
should be very
anticipate.
careful.
We will not know that which
cases. Anticipation is the best thing. No? Then Mudaliar used to say masterly inactivity and watchful expectancy. It doesn't work at all nowadays. You have to be
and we should have a good anesthetist who should give us good coverage.
Yeah,
my anesthetist was very.
Madam, the transfusion should be massive transfusion. It should be adequate, madam.
Yeah,
that is the important point.
Replace blood with blood. So that should be the message.
So how to prevent this? Because patient will ask, no, regularly I had checkup with you. Why you didn't inform me previously like that? If it is like that, where hospital kuda poirpome modale peri hospital ku.
The patient survived. Very விஷயம். We have
lost one patient like that.
As you told, lot of counseling. அதாவது தியேட்டருக்குள்ள வந்து
credit goes to the team who has saved the patient.
Yeah, actually, like when the team was working inside, actually I came out and I was talking with the husband. I was mobilizing the donors, and I was continuously telling them, see, whatever is happening there, like it is an emergency, it can happen to any one of the lot of counseling, madam. And being senior, talking to the patients, attenders, it worked, and thank God she survived. Otherwise, I don't know what I would have done.
Yes.
But she survived this episode, and so ultimately they went home not very happy because the bill was high. So, but anyway, that's it. But we are not lucky all the time.
Yes.
So this is one.
No, you have got a good time, not the patient.
Yeah.
You got a good
Yes, madam.
time and blessed you are. So that you
yes,
are, didn't get into trouble.
Yes, madam.
We have transfused for one patient 32 units of blood, similar to case, but we lost the patient. We transfused 32 units of blood for the patient.
In Dindigul, we had given 84 units for one patient. No? Ultimately, she survived. That is different. But in spite to get 84 bottles in a small city like this is very difficult.
Yeah,
no?
Even in Chennai, for us also, there were so many people who were running around for the blood. But it was in the middle of the night, and from 11 a.m. to 11 p.m. to 1 a.m. That was the time we called help. We called two more friend of mine and anesthetist and senior staff nurses. Everybody came in and they pitched in, madam. So that was a very horrifying experience. But fortunately, the patient survived.
Previously, there was rules, that you should not get blood from outside blood banks. For in a GH, you are not supposed to get blood from outside. But nowadays, they have relaxed the rules, I think. You can get it from a private blood bank. And you should save the patient. In view of saving the patient, you can get the blood from outside blood banks also, apart from government blood banks.
Yes, madam. So the dreaded complication which all of us face day in and day out. But still people love obstetrics, I don't know. More and more. I always think.
When a woman is not ready to help others, who will help, no? So that may be the thing. For a woman should help a woman. That is the thing behind it. Most of them, we have got an intrinsic eager to become an obstetrician, not only for money making. Most as some of them making very bad and raw comments. The obstetricians can earn money. It is not like that. The sympathy and the we are more sympathetic, no?
Yes,
so
yes,
anybody, any woman, if she cries,
we love what we do.
Have a
That could be
passion,
the
madam.
reason.
And we become addicted to what மகராசியா இருங்க அப்படி எல்லாம் சொன்ன உடனே we become addicted to it. That's true.
But nowadays நீங்க ஒரு 10 வருஷத்துக்கு முன்னாடி
அதெல்லாம் ஒண்ணும் வேண்டாம். வர patient any மகராசி, any புகழ், any like that, nobody is going to give you a freedom. That is not the thing. வர்றவ நல்ல பொழைச்சி தாயும் பிள்ளையும் வெளியே போனான்னா அதே பெரிய gift for us. That is the thing nowadays.
Documentation is very, very important, madam.
Yes.
And so that is what is actually going to save us, even if there is a problem with us.
No, I had one second gravida. They came at 12:30, delivered at 5:35 in the morning, early morning. So after finishing second gravida, absolutely previous normal delivery, I just started for a walk. And my staff came and told me that you come and see the patient and go. When I saw, there was a mild trickling of blood only. There is no gush, uterus was contracted. There was mild trickling only. So when I just immediately asked her to put a catheter. As soon as she put the catheter, frank blood came, no? She was a case of DIC without any predisposing factors. Nothing was there. Now, not even I didn't do a PV when she came. Only after the membranes ruptured, I delivered her. So we have to give 13 units of blood for her. The early morning, because the blood banks were open and people were also available around, we were able to save the patient. Suppose if it had gone for a walk, and if I came very late that day, I would have lost the patient. So people were brought from Madurai. Her brother, who is a college student in Yadava College in Madurai, he brought his friends from there to give blood. The whole day I was giving, and only I was able to get her BP and pulse settled at the evening 4:30 p.m. So long we took for her to recover from her this thing. So that happens in everybody's life. But we are seniors, so we can able to face the patients, and they have got some. We have got some commitment to the society, so they are also listening to us. But today's for juniors, it is very difficult. Juniors and somebody who is not in the society. So you should go to the society. So you should have acquaintance with some of the social groups, some form of this Rotary or this Lions Club, something you should have in connection with those, so that you can call, apart from your anesthetist or the obstetrician who can help you. You should have some persons from the society also to come and stand in front of our hospital to protect you. That is the sort of no rowdyism, nothing, no politicians we want. But a person who is interested in the society, you can call and you can explain to them, and you can tell the police also. So if anything is going on wrong, better you immediately call the police also. And then you can tell them that something is going, one patient is getting bad. So we are expecting, like any PPH, it can occur for anybody. Any doctor can be attacked at any time. So always you should have people around you, because in those days, doctors alone can stand alone and they can fight and they can protect themselves. Nowadays, it is highly impossible for a woman doctor to protect herself in her clinic if something goes wrong. So better, that could be the attitude for us nowadays.
Yes,
so
madam.
this is a
Actually,
nice panel.
Actually, like
Yes.
we all should become very active in IMA also, madam, because right now I am holding IMA branch president in Tamram. So here we had a problem in a hospital nearby. Immediately we could mobilize the IMA members along with our members, and we reached the hospital, and we filed a complaint to the police, and we filed an FIR also. So like
crisis management committee should be there always to help you. That is the thing. And some of them, it is a plea for you that we should not make any adverse comment on any of the doctors who had something happen to them. Any doctor sitting away from them, you should not make a comment that no, she would have done this or she would have mismanaged like that. No, they are expecting this type of words from us. No, always this public. So அந்த டாக்டர் கூட சொன்னாங்க, இவங்க இப்படிதான் பண்ணுவாங்கன்னு சொல்லி சொன்னாங்க அப்படிங்கிற மாதிரி நம்மளே தான் நம்மளை காட்டி கொடுக்குற அந்த that attitude should go from us. ஏன்னா இனிமே காலம்லாம் ஈஸியா இருக்க போறது இல்லை. Unless we join together and we protect ourselves, we protect our obstetrician community, we will be getting into trouble only, no? So this is a nice panel, and Dr. Umeya has
thank you, madam. Thank you. So active the panel, madam. Thank you so much.
Shanta also.
Yes, it was very active.
But I think there is a problem in the audio system. Otherwise, all of us, South Indians are growing also nowadays.
Thank you, madam.
It will be also rising to the heights. So thank you for everybody giving an opportunity.
Thank you, madam.
Thank you.
Thank you, madam. Thank you. Thank you.
Thank you, Umeya madam. Nice discussion. Nice discussion.
Thank you, madam.
Thank you, Shanta Devi madam.
Amala madam,
Shanta Devi madam, பாருங்க இருங்க மேடம், அப்படியே ஒரு பிக் எடுத்துக்கிறேன் இருங்க. எடுக்கிறீங்களா? ஒரு பிக்சர் எடுக்கிறீங்களா?
நல்லா எடுங்க.
யார் ஓபன் பண்ணுங்க.
உமையா மேடம், உங்க கேஸ் ரியல் ஸ்டோரி, ரியல் சினாரியோ நல்லா இருந்தது.
Thank you. This was a wonderful session and
Thank
wonderful
you,
meeting with
ma'am.
all the persons in Tamil Nadu society. I find all people are really very wonderful, very knowledgeable, and a great discussion that I have heard from all of you. The case taken were very nice, even for that later on cases which were of infection and the SOFA scoring, and that I heard from Dr. Unmel. They were very nice. And thank you very much. At last, I, Dr. Kanchan Sharma, the folded hand, request you just to bless me, and my special thanks to our chief guest, Dr. Ramani Devi Madam, who amongst all of her busy schedule took time to come here, join and bless us. And the special guest
for having now, advance congratulations, Sharma.
Thank you, ma'am. Thank you for
all the best.
blessings.
All the best for your success.
Your blessings are very precious to me. Yes,
all the best.
madam.
All the best for elections.
And
Just three more days to go.
Okay, bye.
Thank you.
Thank you all, ma'am.
Thank you, madam. Thank you, Kanchan madam.
Thank you. Bye.
Thank you, Shanti Rani madam.
Dr. Amla Devi, Dr. Umyal madam, and Dr. Geeta madam,
Thank you,
Dr.
ma'am.
Revati Janki Raman, who is still logged in, Dr. J Kanan, such a senior person and such a knowledgeable person I have ever met. She is still logged in and gave her full time. And the way she delivered her talk is really wonderful. Last but not least, our academic partner, thanks a lot. I have disturbed them in odd timings and took their help to prepare the flowers and all the things. Thank you, Sahista and Suman and Chitrakala and Raj, all the teams of Shield Connect and all the Tamil Nadu members.
Thank you very much, madam. And it's our pleasure to organize such a nice program at our platform. So in future also, we look forward for some valuable session with you, ma'am. So thank you very much, ma'am, for the nice session.
Yeah.
Thank you so much, Chandra ma'am. Chandra ma'am.
you. Good night.
especially.
All the
Thank you.
best. Yeah. It was very
Thank
nice.
you, madam. Thank you.
Thank you, Dr. Vanita madam.
Thank you, ma'am. Thank you.
Some name if I am skipping. Dr. Shanti Rani, you did.
Thank you, madam. All the best, madam.
Day and night we were discussing.
Thank
and
you.
That time at near about at 12 p.m. we were discussing. You are so devoted. Thank you so much, madam.
Thank you, madam. All the best.